as a JC. So what you can do is you have to pick up the important points, tell what are all the points that is for the paper that help you to take this paper and use their results to incorporate in your practice, or is there any points that is against that will make you not choose this drug or intervention for practice. And the time allotted for discussion, as I told you, is usually 15 to 30 minutes. It varies from center to center. So what are all the basic steps that has to be followed is, as soon as the paper is given, whatever the paper is, how much ever times you have read the paper from top to bottom, I would request you to read the paper from the introduction, from the background to the conclusion at least once. You should also go through their disclosures also. So you should, I would suggest to note down, underline, or highlight the important aspects of the study. Like I will tell you where all the important points will be available during this session, and you can go there directly, underline or highlight the important aspects. I don't think the examiner will ask you to hand over the article to him to present. You can always have the article in your hand, because you cannot memorize something which you have not read for a while. So it is difficult for you also. So you can obviously ask the examiner if you can keep the handouts with you. So the one thing that I would always say is, you should never make mistake of the title of the study, because the title of the study is something that is going to be held throughout the exam viva in that particular station. So make no mistakes in that. The don'ts is, I would don't read only the abstract, because for saying that there could be lack of time, or thinking that you have to read for the other stations like drugs, equipments. These are all other things that you would have read before and went for the examination. But the critical appraisal of the paper research is the only thing that you'll get on spot, and you can read the article completely rather than reading the abstract. Why should you not read the abstract? Because the abstract will not contain the complete information about the paper. It will not contain key details such as the population, what is the intervention that is done, what is the comparator, what was the exact, what were the outcomes that were assessed, and the key methodological points such as blinding and intention to treat or per protocol analysis. Those will be missing. And the presentation of results in abstract will always be selective in abstract, because the authors want to lure you in to read their paper, to make their paper as a practice, to make their study as a practice changing thing, to incorporate their results into your practice. The results will be selectively presented, and that is what makes the readers to go towards that article. And conclusions are usually the author's conclusions, and they need not be supported by the results. For example, the results may say there is harm, the author may conclude that it can still be tried, and further trials can validate it. So conclusions need not be always supported by the results in this article. So with all of these in mind, not reading the abstract, don't go by author's conclusions. This I'm specifically stressing on the conclusion, because at the end of the viva, you will be asked only one question: with this paper in your hand, what is your take home message, or will you incorporate this practice in your ICU? For example, I am going to talk about the Lobit trial, vitamin C in sepsis and septic shock. If the examiner would frame a question that, will you use vitamin C in your ICU practice? If you are using, why are you using? What in this paper had made you use the vitamin C? And if you are not using, what are all the things that was against you using vitamin C? So that is what the examiner will expect. Critical appraisal is pretty much the same, that you should understand how the research is conducted, and how it is analyzed for that, so that you can use it into your clinical practice. So this critical appraisal, we will divide it into four topics. As soon as you get your paper, you try to answer these four questions. What is the research question? And are these results likely to be valid? Can we trust the results? What are all the results? What are the results that is portrayed? What are all the primary outcomes or all the secondary outcomes? How maybe the results be applied? Can we apply these results to my population, my patients in the ICU? This is the four headings that you should answer when you're critically appraising an article. So I will, like I told you, I will go with this article, intravenous vitamin C in adults with sepsis in intensive care unit. This is the Lobit trials conducted by the Canadian Critical Care Trials Group. So the first question was, what is the research question? Where in this you have to divide it into, is there a relevance in asking this research question? Like in this vitamin C trial, is vitamin C in septic shock patients relevant to our context? Do we see patients with septic shock in our ICU? Yes, we do see. And can we use vitamin C? Yes, we can use vitamin C. Does vitamin C reduces mortality or morbidity in patients with septic shock? That is what the research question is basically asking. And does this have any biological plausibility? Is there any biological rationale for using vitamin C? If like for some trials, for example, early neuromuscular blockade in ARDS, you will yourself know what is the biological rationale for using the neuromuscular blockade. In some studies, for example, vitamin C, or for example, if they given you thiamine or using a plasma light or something like that, you might not know. But don't worry about that. It will definitely be present in the backgrounds and methods section. Why is vitamin C useful? In this study also it is present. Like they have mentioned that the vitamin C has antioxidant effects that mitigates the tissue injury, and vitamin C cannot be synthesized by humans, and in critically ill patients the levels of vitamin C are very low. And if you supplement the vitamin C, if you supplement the vitamin C with in patients with septic shock, this might benefit and can be translated into a mortality or morbidity benefit. So the first question among the first division in the first question is answered. Yes, this is relevant. There is a biological rationale for using this. So the next one is PICOS, that is the population, intervention, comparator, and the outcome. S is outcomes, I think. So where will you find this PICOS and why is it important? We will see it further. So the population, you should focus on the inclusion and exclusion criteria. They should have included patients relevant to your context, like their inclusion criteria should be the patients whom you see in the ICU. For example, you're working in an adult ICU and all they have included is a pediatric patient. This may not be useful for you, and this study is not useful in your ICU context. And the exclusion criteria, have they excluded only the patients who needs to be excluded, or are they excluding patients to show good results? You should focus on that also. So this will be found in the population. And in intervention, you should see what intervention is used. In this study, it is the vitamin C. What is the dose of vitamin C? What was the route it was given? What was the duration of vitamin C? And what was the availability of the drug? Is the drug available? And in control arm, you should see if there is a placebo that has been used, the route of the placebo, the duration again, the dose, and what was the other care that the patient has got. For example, we are dealing with patients with sepsis and septic shock, and what was the standard care or usual care that the patient has got. Why is this important? The usual care in some ultimate might be different from the usual care in Medanta Ranchi or in Apollo Chennai. So usual care is important. Where will you find this? It might be present in the methodology section, but given the size and number of word limitation, most of the authors will present it in supplementary appendix. You need not worry about this usual care or standard practice. You can always tell the examiners that, assuming that the usual care is same for like usual care is same for both the groups, assuming that the usual there is no deviation in the usual care, I consider this paper as so that is how you can answer for that question. The next to see is outcomes. What are all the key outcomes of interest that the study is reporting? For example, if in this study, if they say that the vitamin C is CRP levels by day 28, is that important? This might be important context, but this is not relevant for the in patient context. What are we interested? We are interested in decreasing the mortality. We are interested in decreasing the morbidity. If those are one of the key outcomes, then that is something we have to look upon. If they are reporting biomarkers as primary outcomes, then I don't think that this study can be incorporated into our daily practice. So where will we see all of this? First, about the in the patient section, you will see in the methodology, you will see the inclusion criteria. All eligible patients more than 18 years of age who had been in ICU for no longer than 24 hours. Patients of 18 years of more than 18 years of age, they have included within 24 hours of admission. They should have either proven or suspected infection, and they must be receiving a vasopressor. This is pretty much almost the same kind of patients that we are seeing in our ICU. And what are the exclusion criteria that they've used? Contraindications to vitamin C therapy, receipt of open label vitamin C, or expected death within 48 hours, or withdrawal of life sustaining therapy within 48 hours. These are also decent exclusion criteria. They have not excluded, randomly excluded patients. These are all exclusion criteria that those are valid. So the next is intervention. What is the intervention used? Intervention given as a bolus dose, 50 mg per kg. It was mixed in 50 ml solution of 5% dextrose of water. It was given over 30 to 60 minutes every 6th hourly for 96 hours. And the control is matching placebo infusion. They either 5% dextrose or normal saline. So our population is done, intervention is done, comparator is done. Now we look at the trial outcomes. So what was the outcome that they have looked at? The outcome, primary outcome was composite of death or persistent organ dysfunction. Have they defined what are all organ dysfunctions? Yes, they have defined the receipt of vasopressors, invasive mechanical ventilation, or new renal replacement therapy. Are these outcomes of our interest to the patients? Yes. Death is an important outcome, and persistent organ dysfunction is an important outcome to our patients. There are other multiple secondary outcomes that has also been seen in this trial, which also included SOFA, it also included biomarkers, it also included the patient's quality of life after discharge. The biomarkers as a secondary outcomes are still okay, but the biomarkers as a primary outcome, you need not accept this study into it or incorporate this study into your daily practice. So the next question is, first question, what is the research question? We have answered. And the second question is, are these results valid? How will we check the validity of the results? Validity of the results in the sense that they should be internally valid, that the context in which the trial was conducted, the result should be valid. These results should be externally valid. External validity should also be considered, because this you're going to apply or generalize these results into a larger population. So external validity is also something to focus upon. So to check the validity of the trial, you will further subdivide this into three: the trial design, the trial conduct, and the trial outcomes. So the trial design is, did the trial start well? The trial conduct is, did the trial run well? And the trial outcomes is, did the trial end well? So first we will jump into the trial design. What are all things that you have to see in the trial designs? The standard format for publication of the research work is standardized in almost most of the journals. The New England Journal of Medicine, JAMA, or Lancet have standard format in which you have to present these set of the data in table 1. These set of data has to be under the methodology. The other the results has to be presented in specific format. So if you you need not go and search for these where it will be available in the pre-specified places itself. So the first thing that we see is in trial design is randomization. Have they randomized the patient? Yes, they have randomized the patient in 1:1 ratio to receive either vitamin C or placebo. Okay, what was there, and how was the randomization done? The randomization was done by means of a centralized web-based system, and allocation concealment. Since they have done it using a centralized web-based system, allocation concealment is also there. Allocation concealment is different from blinding. In allocation concealment, the clinician will, the researcher will not know what the next patient is going to receive. So allocation concealment is different from blinding, that you should be aware of. And where the groups blinding who are all blinded in the study, the patients, clinicians, trial personnel, and statisticians, all of them are blinded in the study. Next, where the group similar at baseline. Yes, so the pretext of conducting a randomized control trial is that you have two groups in such a way that they are comparable at baseline. So whatever effect that occurs is attributed to the intervention that you have given. Like if the groups are comparable at baseline, if there is a mortality benefit that has occurred after or there is worsening mortality after giving vitamin C, it will be attributed to vitamin C. That is the only reason that you should randomize the patient, and these two groups should be similar at baseline. Where will you find the characteristics of these patients at baseline? You will find it in table 1. So here, if we see, the patients are of 65 years of age. Almost both the groups have same. The female sex is a bit lower, like 35.2. There's a difference of 5% between both the groups. Admission types, medical was the most common type of admission. You can always see the other high Apache 2 score, high SOFA score, high lactate levels, 3.4, 3.4 and 3 in the placebo group. These are all this you should see if both the groups are comparable at baseline, and you can always see that if the patient population that they have included in the study is similar to the patient population that you treat in the ICU. If they have admitted predominantly patients who have undergone elective surgery, and you don't see elective surgery at all in your ICU, and then this study cannot be applied in your regular practice. And that is the most important reason that you should go through carefully in table 1. Mark all the points which is important. You should be aware that how sick were the patients, like in at least in patients with sepsis, and if you're going to see organ dysfunction or mortality as the outcome, then you should know how sick were the patients. You should keep a note of the Apache score, SOFA score, and if other lab parameters such as lactase were present or not. You should also know where the site of what was the source of infection. Uh, uh, that should also be considered, because you may not be working in a burns unit, and burns could be one of the primary source of infection for a that has been conducted. So that is also important. The next search in table 1 is what is the treatment that both the group has received in baseline. Like they have mentioned about glucocorticoid therapy in both the groups. That was also similar. Mechanical ventilation, renal replacement therapy, vasopressin infusion, all these were similar in baseline. You should also know about how these groups were treated in terms of other than the vitamin C and placebo. Like one group should not have received better antibiotics. The other group should not have got a better source control. These should also be mentioned in table 1. If it is not in table 1, then these will be mentioned in supplementary appendix. Given the time constraints, I'm sure that you will not be handed over supplementary appendix, because some of the articles have supplementary appendix which ranges from like 10 to 100 pages. So whatever is in the baseline characteristics in table 1, you will have to be aware of what are all the important points that is in favor for you to say both the groups are comparable, and these are the type of patients that you see in your own IC. So the next is, are the results likely to be valid? Did the trial run well? Was the trial of the conduct valid? You have to see the completeness of the follow-up where the groups treated equally. Like I told you, one group should not have received better antibiotics. The one group should not have got earlier source control. This will be found in the methodology figure 1 or in the table 1. And completeness of the follow-up is one thing that you have to see. In figure 1, this is basically the consort diagram which says that the patient how many patients were underwent randomization and how many were followed up. There can be exclusions during the trial conduct, but these exclusions should be justified. If there is an exclusion from the trial without any justification, you should be suspicious about their results. And in this trial, 872 underwent randomization, 435 and 437 were assigned in each group, and 6 patients were not eligible. By the two steering committee members have told that 6 patients were not eligible, and those 6 were eliminated, and 429 had completed follow-up. 437 in this, 3 patients have withdrawn, and 434 patients have completed follow-up. All the patients who underwent randomization has been accounted for, should be accounted for, and this is something you have to be sure that all the patients have been accounted for. If there is no account, then you should be suspicious about the results of the study. So next is, did the trial run well? Analysis. What are all the analysis? that has been done, assuming that the statistical analysis is done in the right way. We tend to move to the next thing, sample size assumptions. Like what we will touch a bit upon the sample size. And when in this study, what are all the important things that we should look when we are talking about a sample size? There are four things that you should be looking at. What is the sample size that they have included? Okay. Second is, what is the type 1 error rate that they have asked, that they have accounted? What is the type 2 error? What is the power of the study? What is the type 2 error, and how what is the power of the study? The next thing is that what is the percentage of outcome that they expect in the control group? For example, in this study, they have told that the control group will have death or persistent organ dysfunction. Approximately 50% of the population will have it. So this is something that they have said, and they are planning to decrease this death, 50% death by 10%. They are saying, like this study is trying to say that they will reduce the death to 40% in the intervention arm. This is something that you should be aware of. The 10% is a reasonable number for us to have, because increasing the increasing the difference between the group. For example, if you increase the 10% to 20% or 30%, the sample size would decrease. This is one of the methods to decrease the sample size due to lack of time or due to lack of funding. So most of these studies, reasonable studies, for example, the ARDS trials, many of the ARDS trials have the absolute risk reduction by 9%, and the dexamethasone in COVID, the recovery trial had risk reduction by 12%. So the decrease by 10% is an important aspect that you should concentrate on, because someone saying that they're going to show a difference in mortality of 20% or 30% or 50%, that is not going to happen in critical care, because most of the critical care trials have not shown any mortality benefit beyond 10%. Okay. So the next is how have they used intention to treat or per protocol analysis. In this, they have specifically mentioned that the primary analysis is performed in the intention to treat population to assess the superiority of vitamin C over placebo according to the assigned trial group, and the risk ratio 95% confidence interval for the primary outcome was estimated. Okay. So they have also mentioned about the type of test that they have used, and in the secondary analysis they have also adjusted this outcome for a pre-specified baseline characteristics such as age, sex, Apache score, baseline receipt of glucocorticoids, time from ICU admission to randomization, using generalized estimating equations. So I don't think any of the examiners will go deep into the statistical tests that has been done, because one is due to lack of time, and second is like you are still at the level where you're going to critically appraise a paper, and statistics or expecting you to know all the statistical tests and how are these tests conducted is I think it is cruel from the examiner's part if they expect it from you. And you should also see if there was an interim analysis. Why was it a planned interim analysis, or if it was an unplanned interim analysis? Has the interim analysis stopped the trial in between, or the trial has continued? Like I told you, the Rose trial, early neuromuscular blockade in ARDS, they had a pre-planned interim analysis. In the second interim analysis, the trial was stopped. In this trial also, they have two planned interim analysis after 248 and 525 patients have completed follow-up, and the steering committee has recommended to continue the trial. So the sample size, the statistical analysis. In this statistical analysis, they should have mentioned if it is either pre-planned or not, and was appropriate analysis used or not. We consider that this is an appropriate statistical analysis, and was there an interim analysis or not. These are all the three things that you should focus on when you're going through the statistical analysis. This will be available again in the methodological section below the statistical analysis column. Okay. So next is what are all the results did the trial end well. So how large was the effect? did the did the trial show any effect at all? And if at all it shows an effect, how large was it? I think by now you must be knowing that p-value is always overrated, and it is not necessary that every time you should have a p-value in the study. And in this trial, like if you see, the primary outcome was death or persistent organ dysfunction at day 28, and vitamin C, there was 44.5% of patients either died or had persistent organ dysfunction. In placebo group, 38.5 patients had either death or organ dysfunction. There is the usual treatment effect is expressed in relative risk or hazards ratio or odds ratio. Here it is expressed in relative risk. It is 1.21. The confidence interval is between 1.04 to 1.40. You should make sure that the confidence interval is not going through one, so that the effect is appropriate. The You should also see to in the results table too, and additional figures such as the Kaplan-Meier plot, which shows you if there was a survival benefit in patients receiving placebo or vitamin C. There you can see that there is clear separation between both the lines in patients receiving vitamin C and placebo. So with all these primary and the secondary outcomes, even in secondary outcomes, the vitamin C arm showed poorer outcomes, death and persistent organ dysfunction, in terms of death and persistent organ dysfunction. And hence, with these results, and assuming that whatever we have gone through so far, I will say that vitamin C is going to increase mortality in patients in my ICU in patients with septic shock, and I will not try to use vitamin C in my ICU. Okay. If the study limit other consideration is, we should not go only by the primary outcomes. There can be some important secondary outcomes, and subgroup analysis is also important. But subgroup and most of only important subgroup analysis will be given in the main paper. Many of the subgroup analysis will be present only in the supplementary uh, paper. You should also make a note of the adverse events that has happened, because that is also an important factor for you to consider whether to give the drug or. So at the end, like I told you, in the end, after you have appraised the article, you have told that they have included this patient, they've used this as intervention, they've used this comparator, this was the outcome, this was this is how it was done, this many patients. Obviously the question will be will you apply these results to your patients? Yes. In respect to this study, based on these results, I will not use vitamin C in my patients with sepsis and septic shock. The next question, leading question can be like, do you know any other trials that is related to vitamin C or related to any other but any other adjunctive therapies in sepsis? This can further like if it is associated, like I told you, if this table is the one along with the literature review section, the paper itself can take you to the literature review section, because they can talk about vitamin C, they can talk about thiamine, they can talk about hydrocortisone, adrenal trial, approaches trial, ANAN trial, and what is the current surviving sepsis guidelines and recommendation. And the if it is if and they can talk about fluids, they can start in fluids, they can start from the reverse trial to the latest uh, trials that has happened, and what are all the recommendations of the surviving sepsis guidelines. I would recommend you to be thorough at least with the guidelines of the diseases that we see day to day. For example, patients with traumatic brain injury, be thorough with the TBI guidelines, be thorough with surviving sepsis guidelines, be thorough with uh, guidelines for management of ARDS. All these should be you should be thorough about these, because an examiner will not be angry on you when you say that I will manage the patient based on a guideline, and you can always hide behind a guideline when you have an answer. Like for example, how much of will you use vitamin C? No, the examiner might be someone who will be interested in giving vitamin C. You can always say no. The surviving, like I will not use vitamin C because the surviving sepsis guideline does not recommend giving vitamin C in patients. Will you use hydrocortisone? Yes, I will use hydrocortisone based on the recommendation by surviving sepsis guidelines. These hiding behind the guideline is the easiest way to tackle that station and come out of the station harm free. So you should also see the conflict of interest if there was any funding that is, like I told, disclosures and fundings that has happened in this trial. They have been funded by funded, but they have not involved in either planning, coordination of the trial or analysis of data. The authors themselves have initiated and they have pursued with the trial. Is there anything related to this that I can answer?
Do we get meta-analysis for this station?
No, it is usually a critical appraisal is usually a randomized control trial. Being the first batch of DRNB, I have not heard any center giving a meta-analysis. Even in my centers and the friends whom I have talked, nobody have ever told me that they have given a meta-analysis.
So can they ask about how did we how was the sample size calculated? What is the power and the depth of all these things? Alpha.
No, they
beta,
can, like, you should be thorough about the terminologies. Like they can ask you about the terminologies in this. What, like they can ask you about what is a p value, what is a type 1 error, how will you calculate a power. They can ask you about this, but they are going to just ask you about the definitions. They are not going to ask you directly, like, can you explain how have they calculated the power, how have they come into the conclusion, because some of the trials have power calculation done from other trials. So you will you it is not necessarily that you know exactly what the other trial has done, what is the sample size that they have taken, what is the outcome of that trial also. This the point of conducting this session is you should be able to read a paper and you should be able to like analyze the paper and take this into your practice. It is not to make you feel that you should be knowing everything related to the topic.
Okay.
Sir, Tapas sir, you are here, sir? Tapas sir? I think I will proceed with the next topic, current literature review. This is something which you can answer only with the way that you have prepared for your exam, that you have practiced. Because for me, I would share my personal experience. For me, the current literature review started. It was in the drugs table, and it all started with asking with a vial of atracurium that was handed to me overhand. So they asked me, what is this vial, how does this drug act, everything. And it immediately jumped from how, like, do you know any trial that has compared atracurium in ARDS? So I started with the Accurasis trial, which actually used cisatracurium, and I have also told about the Rose trial. With this, they went into what are all the trials which had mortality benefit, what are all the interventions that have mortality benefit in ARDS. So we started with low tidal volume ventilation. I started and then went into prone positioning. Within the prone positioning, they've asked me about the Prosiva trial, and it eventually ended with the ECMO, Caesar, and Eolia trials. So this is how the literature review went. This is one part of it. The next time I was handed a different drug, bicarbonate, and I was asked about the Bicar ICU trial. So it depends on which station you are, like, this is combined with, because there's going to be only 4 examiners, and out of these 4 examiners, whoever is interested in taking the current literature review, some of them might combine it with this critical appraisal itself. It can be either with your thesis along with your current literature review. It can be with drugs, like it was given to me. So this is something that you can never anticipate that they are going to what are they going to ask you about. I'll just give you 2 examples of what all, like, what are all is sufficient for you to answer, because this current literature review, they won't expect everything from top to bottom about an article. It is like, what is your knowledge about the topic, and are you like, your knowledge is your knowledge based on current evidences, or are you just like doing using it by your own assumptions? That is what they want to know from you. So the current literature review, like it is a mostly like it is a table viva only. So it will start with, like I told you, it will be a topic of interest. It can be your examiner's interest, or it can be a drug that I got. It can be a paper which you're holding in your hand for literature review, and any of the recent trials can also do. So they might usually focus on sepsis trials, adjuncts in sepsis, ARDS trials, ECMO trials, fluids, AKI. It is not mandated for you to know the exact year of publication of the trial, how many patients were included. You should be aware of the important results of the trial, and if what is the primary outcome of the trial, and the primary outcome, if at all you know the primary outcome, and what was the trials trials outcome in terms of the primary outcome. So the be thorough about at least about the primary outcomes. That is all what I wanted to emphasize. And don't jump into conclusions based on one trial. Like, you know about the recent one is like I told you, early neuromuscular blockade in the Rose trial. You don't jump into based on that trial alone saying that no, sir, this trial has not shown any mortality benefit, so I will not use any uh, neuromuscular blockade in patients. Your examiner might be a person who doesn't agree with the trial investigators. He can also be someone who is pro for giving early neuromuscular blockade, and he can always have his assumptions. And you cannot just outrightly say that I know based on this trial I will not use. You have to be polished while answering. Try to understand what the examiner is expecting from you, and if you answer it in a polished way. Though this trial has stated, if you have some biological rationale, for example, there will be pleural swings will be high, there will be trauma that can electrotrauma that can happen, that can be barotrauma that can happen, all these things. If you can justify saying that this trial, I feel, and there were limitations in this in that trial also. Like, many of the patients have not been prone, which is a standard of care. Like in when compared with accuracy trial, if you say those and say that I would still consider paralysis based on this, then the examiner might not be offended or be angry on you, because you're just not changing your practice based on one trial, because one trial is the trial alone. It is not going to change the entire practice. There are very few practice changing trials. So, example, like if we start with what are the ideas about early RRT initiation? We like how do you initiate RRT in your ICU? They can give you an example, like a 69-year-old male in sepsis, septic shock, has developed an AKI. Like, your creatinine was 0.3 yesterday, and today it is like 4.5. Urine output is 30 ml per hour. And will you start? Will you start? They can give you a scenario, and they can ask you to substantiate your points. So with this, if you know that if the station is going to be a current literature review, you know that what is your routine practice. What your routine practice might be to start an RRT only when it is absolutely indicated. The important points where RRT is indicated, like edema, anuria, hyperkalemia, severe metabolic acidosis, all these stuffs. Then you start by saying that I will start, supported by the results of this trial. They can ask you what are all the trials that you know of in RRT that has happened. You can say that it started in 2002, no difference in mortality benefit, early versus late RRT. The first trial that showed a mortality benefit was the Align trial. Early RRT was associated with 90-day decrease in mortality. Then came the Akiki trial, then the Ideal ICU trial, then Start AKI trial, and in the end, there was this Akiki 2 trial, that is delayed versus more delayed. So, like I have put this is easily available in the websites. This is an important Nephro JC is an important website where you can get all the nephro trials. You have to select out the critical care trials, and there will be visual abstracts of all the trials or comparison of all the critical care trials. Like, there will be something on fluid, there will be something on early or late initiation, there will be something on bicarbonate. If I would like, this is too late for us, for anybody to go and select, but whenever you're free, it is, if it is possible, just go through the site, copy and paste this images in a folder, so that during your travel or whenever you're bored, or during your food or something, you can just go through the trials, but only at the primary outcomes. Like, I would start with the Align trial. was the first trial that showed benefit in early renal replacement therapy. This is basically a single center trial. What was the criteria that they've used? Early KRT renal replacement therapy was within 8 hours, delayed was within 12 hours, or no initiation. What was the difference? 90-day mortality, there was a difference, 39%. 39%. You can say, just say that there was a difference in 90-day mortality. That is all is enough for you to say. And was there any complications? There was no complication. What was the limitation of the study? I personally feel that I have been on the other side of the table, only from the examinee's point of view. The examiners I have always faced from the people who I have studied, my teachers, and the exams which I have attended, the FAT exams, 2 or 3 FAT exams, and the model practicals which happened within the city, and the other exam, like the final exam which I have attended. In a station like this, people won't expect you to know the exact number of participants. They will just expect you to know, do you know anything about the trial at all? Do you know at least if there is a trial called Align trial, or if there is a trial which has happened which showed there is a difference in mortality or not? That is all they want to know. Next came the ACLS trial, which is a RC randomized control trial, which multicentric. Here the eligibility criterion was KDIGO stage 3 AKI. The early was 6 hours. The late was either life-threatening complications. There was no difference in 60-day mortality, and complications was CRBSI was higher in early group. Similarly, the next one was the ideal ICU. Same, early was within 12 hours, and delayed was 48 hours after randomization. If the kidney recovery did not happen, there was no difference in either in any of the primary or secondary outcomes, and limitations were non-blinded. The next comes your START AKI trial. It is again a multinational multicentric trial, KDIGO stage 2 or 3. Higher KRT dependency, 90 days in accelerated arm, no difference in primary outcomes, and there was heterogeneity in group. That is one of the main limitations. Like this, now you have 5 trials. If you have to summarize all of these trials together, the most common outcome that you have taken, like you have come across, is there is no difference in mortality between early and late except for the end trial. This is all what you wanted to know in all the trials among the AKI for RRT for AKI. And was there any any other differences? Like some of them have looked into MAKE 30, major adverse kidney events, uh, on day 28. And was there any complications that has happened in delayed RRT? So this is all what you should know. So if you have to summarize or find, say that what do you think about these trials? See, first of all of these trials have been conducted one after the other, one after the other, one after the other to prove, but the eligibility criterion is different for many of the studies. Like one has used a stage 2 AKI, the next one has used stage 3 AKI, the ideal ICUs used rifle failure criteria, the KDIGO START AKI used either 2 or 3, and AKI 2 used 3. So the criteria, like what is early, what they have mentioned as early, within 8 hours, within 6 hours, within 12 hours, within 12 hours, within 12 hours. Late also there is a differentiation within 12 hours. Some is with life-threatening complications, some is within 48 hours, some is more than 72 hours, and some is again life-threatening complication of EK. So with this thing combined together, if you want to take something out of this, what I would take is, I will say that I will not start RRT for patients with AKI unless there is an indication for RRT. I will not start it within 72 hours. After 72 hours, I will not start with after 48 hours also. So this is what is going to be my take home message based on the 5 trials together. This is what the examiner will also expect from you. So similarly, what is the rationale for using balance all solution? Will you use balance all solution? These are all the 5 trials that has happened. So like the important trials that has happened, and there are multiple meta-analysis that have happened also. So if you want to know what has happened exactly in this, a meta-analysis which includes all these 5 trials would be more than sufficient to tell you which trial stands where. But due to lack of time, you will not be able to go through a meta-analysis or find a meta-analysis. Like I told you, what is your take home message? Will you use plasmalate 148, ringer lactate, or saline alone? So the latest trial, the plus trial, which was published in 2022, there was no difference in mortality. There was no difference in renal replacement therapy. There was no difference in ICU stay. There are no difference in ventilator-free days. So it is almost the same in almost all the trials. Split, no AKI difference. Salter, no difference in hospital-free days. No lower make. There is only make 30, lower make 30 in balanced crystalloids. In SMART also there is lower make 30, low difference in mortality. In basics also no difference in mortality, no difference in AKRRTUs. So with these trials together, I would say that like I will prefer I will not preferentially prefer plasmolite over normal saline, but my examiner might be like my examiner was more pro for plasmolite, and when I have guessed that I've told her that I will use plasmolite in specific subset of population and in patients whom I need large volume of resuscitation. You just have to justify your answer. So this is pretty much what current literature review, current literature review is, because this is extremely a vast topic which cannot be completed at all. And I have told you like 10 different topics which can be asked. There can be, the examiner can ask extremely different about pulmonary artery catheter also, but you cannot do anything about it. Whatever you can say is try to say something that you practice, because I hope most of the institutions practice evidence-based medicine. Thank you.
Yeah. So thank you, Dr. Gautam. That was really elaborative as well as quite helpful for the candidates, and definitely they would get some idea how to approach this session with confidence. So that's all from the first session. There are many things Dr. Gautam has told, though that is not possible humanly to discuss about all the details related to research, which is a I can say a bland topic towards the end of your preparation to read in detail. So you have to go through the important points that would be really helpful to at least answer the questions. And after clearing your practical exam, maybe some of your interested candidates can go through in detail to know about research, critical appraisal in detail. So with this, we come to end of the first session. So I'm just sharing the next one, which would be so there are something has been done. So I would be sharing my screen, so it won't be there. So please, I request everybody to not put some lines in my screen, because that is actually irritating the candidates who are watching it online. So please don't scribble anything on your screen. So there are questions. Is there any question? No. Okay. So I'm just sharing the screen with you all. Dr. Gautam, thank you very much for taking such pain to prepare this presentation.
Thank you, sir. Thank you. And all the best to all the candidates.
Thank you, sir.
Just 1 second. I'm just sharing the screen with you all. Perfect. So is my screen visible now?
Sir.
Okay. So I would be talking about a station which we don't know how our fate will be there on that day. So this is something which we can say a table with no clear-cut guidance how the questions would come. And there would be no drugs, there would be no equipments, there would be no chest x-ray, there would be no equipment, there would be no ECG, there would be no, I can say, clinical cases. So this is something which is, I can say, the examiner's domain. So they can ask you and they can drag you to any extent on this table. So that's why this table is something, I can say, a table with no idea how your fate will be. So before going into detail, the topics that I have selected, so there are something which I would be sharing with you the titles, topic titles that you can just go through in a short paragraph, because these are some of the topics which the examiner don't want from you in detail. They just want to know that you can say at least 5-7 lines. So just a like simple question I will be starting with. Doctor, you are a trainee. You are now joining this hospital as a consultant critical care. So in your hospital, it's a 20-bedded ICU. Suddenly, there is shortage of nurses as well as few of the doctors have left. So now you are a completely full ICU in your hospital. So how you are going to allocate the resources and how you are going to manage your ICU? So this is something they would be trying to know how smartly you can answer, making it very clear how smartly. Maybe there won't be any scientific typical guideline related to answer, but yes, it has to be something which is reasonable and it makes sense. So that is the idea behind putting this type of questions in this table. Now somebody may be interested to ask you, doctor, you are the team leader and you want to educate your nurses as well as your junior doctors related to critical care. So how you can start education in your ICU, or how you can imbibe the culture of research, doing some research in your ICU? So that may be a question, and they would like to know from you what are your ideas, how you can defend this question. So this is question number 2. Now relate to ICU administration. So how you are going to make the portfolio in your ICU, how you are going to divide your duty hours, how you are going to put some of the key service team leaders like the clinical pharmacist, the nutritionist, the physiotherapist, and how you are going to divide the workload among all of them. So this could be also one of the question. Conflict management, they would try to create a scenario, and they would create a scenario that there is a conflict of management protocol between your primary team and also the supporting teams, and how you are going to manage this type of conflict if you are the team leader. Related to palliative care, end of life care, I hope you have all read it, you have all gone through the questions during your theory preparation also. So there would be many questions or scenarios they can create and they can ask you in this table. Withdrawal of care, which is right now one of the concern and one of the things that is still not very clear. It's a gray area, but I expect that as you are going to be the consultants in your hospital, some of the new hospitals, so they would be asking about end of life care in detail. Then building teamwork, how you are going to make a dream team. So that may be one of the questions, and these questions have no that you have to talk about some of the guidelines, some of the referred articles, some of the things that would be taking 10 minutes of your time. They would be asking you 5-7 questions, and each question they would expect at least 2 to 3 minutes of your answers. So that is the essence of this table. Performance improvement, they would create a scenario that your ICU, your hospital, suddenly you are getting that there is collapse rates are increasing in your ICU. So what are the measures that you would do, implement as team leader, that would be directed to reduce the incidence of or prevalence of the collapse in your ICU? And finally, some of the severity scores they would ask, some of the admission criteria, discharge criteria, shifting to the step down unit, what are the the guidelines, what are the SOPs that you can make in your ICU, in your hospital. So they can ask you some of these questions. The questions that I want to discuss in detail, the first one is clinical audit in critical care. How many of you have been involved in clinical audit in your ICU? Can anybody tell me? Can anybody tell me? Clinical audit? What do you mean by clinical audit in critical care? This is a very pet question in the practicals by some of the veteran examiners. If they are into you are doing very good, they can ask you something related to clinical audit. Anybody? What do you mean by clinical audit?
To compare the structure and performance and process with the explicit guidelines, and then review the changes which have been ordered, and ensure the improvement in the critical care.
Okay, very good. What do you mean by explicit criteria?
Some standard guidelines, national guidelines. Sir, I don't remember the name.
No problem, no problem. At least you are on the track. I would request all of you, all the candidates, to just start talking, because anyway, after 7 days, you have to talk. Otherwise, you have to wait for 6 months or 1 year to again talk. So this is something which we expect. This is not related to session. Please don't take it in something personal, but we want to make you having happy faces at the end of your exam. And the essence and the trick, what is very important in practical, just continue talking. Whatever you know, there are people who doesn't understand the question, but they would start with something, and they would also confuse the examiners. And the examiner would finally feel that this candidate is really smart, and they would give the answers, the marks to the candidate, and they have also passed. So when we asked about the performance by the candidates in the exam, so they told that whatever the examiner asked, they tried to just be smart in answering and talking in a little bit of a different way. So somehow some of the candidates have also clicked in that way. This is not the right way. I would not advise you that to just apply whatever you know and start talking. But the essence, the whole idea is you have to answer the questions, whatever you know, because it's only 7 days or 10 days before your real exam is there. So you don't have time to again read. So the Viva questions related to this session. I asked some of you, what do you mean by clinical audit? This can be a straight question. And if you answer this question, then the next question would be, is it so important in critical care? Then if you say yes, the examiner would ask you why. Then no, the discussion ends there. And you would be sent to the next table with a big, I think maybe out of whatever 25 marks, you would be getting hardly 5 or 7 marks or so, like that. And if you answer the third question also rightly, then the fourth question would be your bonus point or your honors point. How do you do a clinical audit? That means you are a consultant material to me. So the examiner would be so impressed that he or she would be just considering you that you are a consultant material. You are already deserving to be a consultant. Do you all agree with me? If the questions the examiner would be asking you one after another like this, how far you can take the examiner into discussion, that you have to introspect. Now, for all of you, definition, these are some of the topics, very bland topics, I know. So that's why I have written it completely, the sentences, that you can understand, you can remember, because you won't get enough time to again some of the books or some of the articles and prepare, because you have very less time in remaining days. So a clinical audit is a quality improvement process that seeks to improve patient care and outcomes through a systematic review of care against explicit criteria. Am I clear? So this is a quality improvement process. Everybody understand this? That seeks to improve patient care and outcomes through systematic review of care against explicit criteria. And explicit criteria, it is through the consensus guidelines, through the position papers, through some of the groundbreaking research, some of the already told by your colleague, the national guidelines, the practice papers, some of the standard books. and well conducted RCTs. So they have suggested some of the like criteria that yes, the care should be like this. So you are following your like standard of care, what you are doing in your hospital based on the that benchmark. So that is the idea. So you have to understand the clinical audit, then only you can answer in your own language. Now, why like the clinical audit is so important to critical care? Because it ensures adherence to the best practices right now what is happening worldwide in a high stakes environment, and ICU is I think the best example of high stake environment. We normally like do our clinical work there, and we know that this is something which is the perfect place to conduct clinical audit in the hospital, whole hospital. Now the third question, if you answer this yes, saying why we need clinical audits in critical care. So I have just enumerated these points. You have to just understand it and try to remember. Because in ICU, we want our patient to improve. And as a result of which, we have to ensure that our patient should be in like a safe environment. So improving patient safety, and that's the result what we will be giving. That is the outcome. We have to ensure that the best practices are being like adhered in our ICU, and both the doctors, the nurses, the like other healthcare workers are sticking to the best practices. So that is the reason why we need clinical audits, and we need to have our own SOPs, our own standard, the compliance rate, and then on that basis, where we are lacking, we need to address those concerns. Third point, identify the areas of improvement. That means we have to uncover the deficiency or gaps in the care. So if you do not conduct clinical audits, so we will be totally like I can say blind. So we are doing our work, but we don't know where is the problem. So we will be only getting the final results, but we don't know how to like improve our clinical standard from the current situation. Fourth one, it's a multidisciplinary environment. So we have to enhance the multidisciplinary teamwork by facilitating better communication and also good collaboration among the team members. So that's the reason also we need to have clinical audits in our ICU. Then as a result of clinical audit, that would also facilitate continuous learning and education. So audits can reveal areas where is actually we are not able to reach. So if your nursing care is actually poor, so we need to have a clinical audit in some or other way, and we can find that yes, the awareness for doing that type of work which can improve the clinical outcome is not there. You can engage somebody to teach, somebody to take classes, somebody to like address the concerns that you are getting through your clinical audit. So these are the 5 points, first important 5 points. We have more points also. Resource optimization. Your ICU is having enough resources, but somehow the result is not good or like not expected. So you have to find out maybe there are certain inefficiencies, and maybe there is not proper optimization of the use of resources. So both are important to like continue the sustainability of the healthcare system in your hospital. So that's the reason also we need clinical audits. Maybe you have the instruments in your hospital, equipments in your hospital, but they're not being used properly. So in clinical audit would give you the idea that yes, we need to remove some of the old instruments or equipments, and we need to involve or engage some of the new equipments or instruments. As a result of this clinical audit, we can improve our clinical standard, and as a result, we can enhance the patient trust and institutional reputation. So that is also one of the reasons why we need clinical audits. Compliance with legal and ethical standards. If we do regularly the clinical audits, so we'll be improving our like the quality of care in terms of the legal, ethical, and professional standards. And that would also reduce the risk of litigation, and also it would be enhancing the ethical quality of care. Ninth point would be your hospital, as a result of clinical audits, frequent clinical audits, you will get to know the exact standard of your hospital, and it will be helping you to drive policies and clinical guideline development. So you can have your own policies, SOPs, clinical guidelines that can improve or shape the best practices based on the explicit criteria, and that is the based on the real world data, right? Now, 10th point would be benchmarking and external accreditation. If your hospital is applying for NABH, your hospital is applying for JCI or some of the reputed hospital affiliation or endorsement. So these are the some of the clinical audits that you can present. So that would be helping you to get the external accreditation as well as recognition. Clear? So these are 10 important points. If your examiner would be asking, I have elaborated it to 10 points. So at least you can tell 5 points in the examination. Clear? Now, the next question would be, you are answering till now perfectly well. So the next question would be by the examiner, how will you conduct the clinical audit? So you have to go in again in a systematic way. And if you know, you understand, then you can reproduce on the day of your examination. How? I would be going one by one. Now see, you have to first select one clinical audit topic. So the examiner would ask you, what is in your mind going on? How would you select a topic that would be relevant to your clinical practice? So you have to explain the importance of choosing a relevant and significant topic in the critical care for the audit. Like in my hospital, if there would be 10 important things, so I have to choose the most important, that the patient is on ventilator, and most of the patients, the tracheal secretion or tracheostomy secretion is coming as Klebsiella or Pseudomonas or like MDR, XTR, PDR. And as a result, what is happening, the mortality, morbidity is getting affected. As a result of that, I have to use some of the higher antibiotic. As a result of that, the antibiotic resistance is increasing. I am using antifungal frequently. So many things are happening, and that is right now directly costing me a lot in terms of the quality of life of the patients, in terms of the resources, in terms of the ICU length of stay. So I would choose ventilator associated pneumonia, adherence to the sepsis guidelines, or post-operatively, or like in my ICU, if my patient is having polytrauma, how I am going to manage the pain in my patient. So this is something related to selection of the audit topic. Now, the next point would be setting the standards and criteria. You have to derive from the best practice guidelines or expert consensus that this is the standard, and I have to assess my hospital standard. So mention the need for specific measurable criteria to assess performance against these standards. Clear? So you have to set your hospital standard that yes, worldwide the VAP rate is supposed to be this, and my hospital is currently having this. So my target is to take it to the level, not maybe the exactly Western ICUs, but at least I would be targeting that I would be reaching near that mark. Third point would be data collection. So I have already selected the topic. I have already set the standards and criteria. Then I have to collect the data, the real data. So I have to outline the methods for collecting data, such as reviewing, maybe retrospectively, I have to go through the patient records or observing the care practices. Now, stress the importance of collecting accurate and relevant data to assess current practice. This is again very important, because if you are getting only the crude data with no proper selection criteria or the compliance rate, maybe the result or the clinical audit, what you are going to do would be giving you some result which is astonishingly surprising for everybody to believe. Maybe it would be reaching the Western ICU standard, though your ICU is not having that type of infrastructure or practices, or it would be something very disastrous, and that it would be very difficult to believe. Now, after this data collection, I have to analyze it. So you have to again discuss the comparison of the collected data against the set standards. And again, you have to emphasize identifying areas of compliance and deviation. Now, fifth point would be, then I can know from my analysis that these are some of the areas which needs to be improved. So identifying the areas for improvement. How? Explain how the audit helps identifying areas where practice in your hospital doesn't meet the standards right now set worldwide, or some of the best institutions, or some of the research guidelines, or some of the consensus statements. Now, mention potential reason for the non-compliance. You have to be very honest. Like, yes, resource limitation is the reason why we are unable to reach that standard, or knowledge gap. This would be something very practical way. That type of the knowledge in my healthcare workers, they can like do till that level, but not to the best level. Now, then after that, you are now with the results, and where are the areas how you can improve. Now you have to implement some changes in your ICU, in your like the clinical practice. So you have to develop one action plan to address the identified shortcomings, and that would be, if it is knowledge gap, go for staff training, protocol revisions, or it is resource limitation. You cannot make it just in one day resource rich station, or like the setup. So you have to allocate it wisely. So the resource has to be allocated in a proper way, that the sick patients or the areas which are actually in real problem, so they need, or they are being supplied with the correct resource. Then 7th point, after 6th point, the work doesn't end there. Why? After implementing all the staff training, protocol revisions, resource allocation, or some of the best minds that in your hospital, your ICU have done their work, you have to again re-audit. That would be the final stage. Then highlight the importance of re-auditing to assess the impact of your changes, and explain that how re-audit helps in ensuring that improvements are sustained over time. So it's not the one time that you have done something, you have tried to change the practice, and you got some good results. After maybe 3 months, 6 months, your the curve, the graph would be slightly start dipping. So you have to maintain it above the or at the level of the world standard or explicit criteria. So that's the reason why you have to go for re-audit in some of the areas which are vulnerable to deviate from the standard practice. I think I'm clear in explaining clinical audit in one slide. Is there any doubt at this point of time? Is it okay now?
Do we need ethical clearance, sir? Institutional ethical clearance for conducting audit?
Look, institutional ethical clearance, we are not doing a typical research. It's an internal data analysis. So you are not going to send the clinical audit report to some of the higher authority. Maybe you can discuss all these things with your the hospital administration. So it's not always mandatory, but yes, if you are doing something which would be sometimes would be taking the patient's data, and that you are planning to present some, or trying to do some such paper, write some article, and in that case better you will be taking the ethical clearance from the very beginning. Like if you are doing some re-audit and you are getting real improvement in your clinical practice, and now you want to present it to the your state level, national level, or you are writing some paper, definitely you have to take the ethical clearance. Now, preparing for audit, I have already mentioned it, but they may ask you how you would be selecting a topic. So it has to be high risk process, serious quality problems, or clinical evidence or guidelines, robust guidelines are there. Then only you have to choose related to that topic. That makes sense. We can make, or we can select any topic for clinical audit. But if I'm choosing some topic which is not very clinical relevant, this is not going to change the mortality and morbidity in my hospital to a great extent, and the quality problem is not there. So it doesn't make sense to put so much effort. And again, maybe utilizing your resource, there would be manpower utilization. So you are actually not going for any drastic improvement after doing this clinical audit. So that's the reason why you have to select a topic which is quite relevant in your ICU in your hospital. Now, what are the topics that you should choose? The examiner may be interested to know. So you can divide into structure of the organization. That structure of organization, I am giving you a clue. 3M, not 3M company. Man, machine, materials. Man, nurse is to patient ratio, unauthorized absence in your hospital, in your ICU, in your in your doctor pool, in your nurse pool. Then you can do a clinical audit. Why this is happening? Why the absenteeism is so high in your ICU? And you have to find some reason, and then you have to act upon that. Related to machine, it would be critical equipment downtime. Most of the equipments in your hospital, most of the time, in the real need of the time, it is not working. It's in the calibration. It is faulty. If you are asking for the IBP, the nurses are unable to connect correctly, and the data or the graph what you are getting in your ICU is not up to mark. So this is machine failure. Why it is happening? So that is also a clinical audit subject. Materials, adequacy of emergency drugs, out of drugs. Really take one clinical audit, patients, septics of patients within the stipulated the window period, the first critical hour. How many patients are getting the antibiotics in time? That could be one of the clinical audit, and that can improve the outcome also. And we know that every hour delay the mortality by
7%.
7%.
Okay, very good. Second one is process. First one is structure. Second one is process. In that also you have areas where you can do the clinical audit. One is initial assessment. In what time your doctor, your junior doctor, your consultant is actually taking the round and you are assessing the patient. Periodic assessment, how frequently you are doing the assessment. You have today, right now at 8 a.m. you have seen the patient. At what time you are again coming to the bedside and assessing. PAC related to anesthesia. Is it being done correctly at the right time? And is it being addressing the issues that actually the patient is having post-operatively? The issues have been actually dealt with pre-operatively and the patient's outcome is improving. Prophylactic antibiotics in the OT. This is very good a clinical audit. Most of the hospital, they have their own SOP. Rational use of antibiotics for pneumonia, UTI, SSI, meningitis, appropriate use of blood components, appropriate use of sedatives and narcotics. Is your hospital, your ICU is having proper protocol, when to start, when to stop, appropriate pain control, post-surgical, hand hygiene compliance, effective CPR compliance, bundles compliance, readmission in your ICU, medication error, adverse effects of high alert drugs. So there are n number of numerous the clinical audit topics that I have actually showing you right now at this point of time. Then maybe you can also have something related to outcome. Look for complications patient safety complications, mortality of drug resistant bugs, ventilator mortality. Whenever any patient is put on ventilator in ICU, so 90% patients are dying. That could be also one of the clinical audit topic. So you can find out what is happening. Is it because of the ventilators are malfunctioning? Is it because that the nurses are unable to actually handle the troubleshootings? The doctor is unable to find out the the tube kinking, or the secretions are being clogging the tube. Acute MI. Any patient coming to your emergency department with chest pain, 90% patients are dying. And finally, you are getting the ECG elevation or non-ST MI, but the patient's mortality is really high. Primary angioplasty mortality, something related to cardiology. Hospital acquired infections, pressure ulcer. So these are some of the topics, and the examiner may ask you related to the process, related to structure, related to outcome. Can you give me examples of some of the clinical audit topics, what you are right now doing in your ICU, or have you come across any of the clinical audit topics? Selecting criteria, I have already discussed. Explicit rather than implicit criteria should be preferred. It's not like you are targeting something in your own city. It is something which should be in from a standard reputed journal or some of the standard consensus statements, and you are trying to get the evidence from that only. And selected research evidence that whatever you are doing, the processes that have an influence on the outcome and measurement of the process of care is more sensitive and provides a direct measure of the quality of care. And whatever you are doing, the outcomes are clear, influenced by the process what you are doing, and they occur within a short period. It's not that you are changing some of your like the guidelines in your hospital and the outcome is almost taking 1 hour to be reflected. There is no point of such type of audit. It has to be short, crisp, and the results have to be also immediately maybe like appreciable if you are implementing some of your changes in your hospital, in your ICU. This is one of the example of clinical audit. This was one of the like the audit that has been done in Journal of Royal College of Physicians, London, and they have like done the CPR, and they have audited that how with the like the use of CPR, how the system could be improved, whether the existing training program was adequate and well directed, whether the survival rates after putting your patient on the CPR, high quality CPR, is reasonable and compared to the worldwide. The audit, just for the sake of understanding, the audit revealed in this audit, they found that a need to improve telephone connection to the hospital switchboard. At that time, it was not having mobiles, so they were calling to the nursing stations or the doctor through the land phones. So the audit revealed that yes, we need to modify some of the equipments and we have to improve the knowledge of the geography of the hospital site. That the third floor, the corner room is having code blue. So that geography of the hospital site, most if your doctor who should be coming at the right time or before time, they don't know where is the third floor corner room. That would be completely confusing. They would be running here and there and unable to get the proper like the placards or the signage that would be like guiding them to the concerned room where the code blue has happened. So changes in emphasis in the training program will alter the process of resuscitation, and they compared with and they acted upon that, and that would be the benchmark for the quality control in their hospital. So this is one of the example I tried to give you so that you can understand that yes, these type of things also can be done in your hospital, in your ICU. Now the next question, is there any problem, any doubt in this clinical audit? This is something if you are answering well, you may be eligible for gold medal. And I hope all the candidates who are right now online, they would be getting 1 gold each.
Sir, if they ask
now the
whether
second question,
sir, if they ask whether we have conducted any audit during training, should we be honest that we have not conducted?
Yes, you can be like very honest, and you can tell that I am not been part of the clinical audit because these are some of the clinical audits that being conducted by the staffs in our hospital, in our ICU consultants. But yes, we know about how to conduct the clinical audits and the concern for like conducting the clinical audits and how it can improve the outcome, and you can explain well rather than like mentioning something which you have not done. Rather you can explain them, yes, we understand it, but yes, as a trainee we were not part of the clinical audit. That would be very like I think very precise in answering this type of question, right? Okay, now the next question, very important. On the last year there were like 5 or 7 candidates from our course. They just submitted or shared their feedback that they were asked about quality, how to improve quality in intensive care unit practice through the clinical audit. Yes, the clinical audit is there still here, the title also clinical audit, but it was related to quality improvement. So I'm just sharing with you some of the quality measures in as per like some of the standard society, and I am referring it to ESICM quality indicators. You can mention, they would say, can you tell me some of the quality indicators your ICU should be having? So as per ESICM, I have just taken this from one of the article. ICU fulfills national requirements to provide intensive care. It should not be a nursing home ICU where the basic facilities or the requirements of ICU is not there. So that is first quality indicator. 24-hour availability of a consultant level intensivist. In ESICM, in European ICUs, this is the standard. Presence of adverse incident reporting system. So that is also one of the quality indicator. If your nurse is having some or other problem and he or she has administered inadvertently some of the wrong drug to some of the patient and some of the adverse effect has happened, it's not a big deal. But is there any system that you are doing some root cause analysis? Is there any report, incident report form your hospital is having? That is also a quality indicator. Presence of routine multidisciplinary clinical ward rounds. Maybe it would be appropriate to the ICU. You are having a grand round where other service providers, healthcare providers like clinical dietitian, nutritionist, or the physiotherapist, pharmacist, and then the counselor, they are all with you or not. Standardized handover procedure for discharging patients. I think if you are part of the NABH assessment also, I think you must be knowing this type of quality indicators. Some of the accreditation, this is the basic mandatory requirements your hospital, your ICU should be having. So they normally come and check your handover book or takeover book. Report and analysis of SMR. Hospital is having Apache 2 or Apache 4 form, whether your hospital or ICU is analyzing this Apache 4 Apache 2 data and finally having SMR. Can anybody tell me what do you mean by SMR and what is the normal value? This is some of the statistics question.
It is a observed mortality upon expected mortality.
What is the normal value? What, like, how will you
Less than 1.
less than 1? If your ICU is having more than 1 SMR, what do you mean by that?
Observed it is more than risk adjusted rate.
So what do you mean by that?
Excess of the standard.
What is the interpretation? Substandard. Okay. Okay. Now you have to read this SMR. This is a very favorite question of the examiners, and some of the important statistical questions like NNT, then ARR, then standardized mortality ratio, odds ratio, forest plot. Some of this is related to critical appraisal, but yes, that can be asked in your exam. Just I have taken the opportunity to tell you. Then readmission rate within 48 hours of ICU discharge, rate of unplanned endotracheal extubations, rate of CBC related bloodstream infections. These are some of the quality indicators. Now, again, in the adult critical care clinical reference group quality indicators, percentage of total available critical care bed days utilized for patients more than 24 hours after the decision to discharge. Can you understand? This is also one of the quality indicators in the American ICUs, Western ICUs, that you have decided to discharge the patient, but because of some or other reason, the patient is being the bed is being utilized for the same patient more than 24 hours. Percentage of patients discharged from critical care between 7 o'clock till the midnight. Then what are the patients readmitted to critical care within 48 hours of discharge? Rate of unit acquired infection in the bloodstream infections, standardized mortality ratio. So these are some of the quality indicators. If your examiner is asking, just don't stop. Mention about at least 5-7 quality indicators and you will be getting the full marks. Now, there are maybe some of the questions like safety and errors in your ICU. Quality we have already discussed. Now, somebody may be asking you, what do you mean by quality of care? So there is a WHO definition. It is the extent to which healthcare services provided to individuals and patient populations improve desired health outcomes. Clear? So this is the WHO definition, that this is the extent how you can improve the healthcare services to the level of desired health outcome. And to reach the goal, the healthcare providers have to ensure that the care is safe, effective, timely, efficient, equitable, and people-centered. These are some of the terms if you are using, then the examiner is forced to give you 10 out of 10 or 25 out of 25. So this is the art of like talking in a very smart way. Definition of safety and errors. Freedom from an accidental injury is safety. Clear. And failure of a planned action to be completed as intended. Of a wrong plan to achieve a goal. Error of execution, error of planning. For these two sentences, error of execution is also error. Error of planning is also error. Freedom from an accidental injury is safety. We are safe that this earthquake has not affected any of us. So that is again like no safe. This is the example of that. Measurement of safety. They may ask you, can you measure the safety? It is subjective. It is not easy to measure quantitatively, but can be measured based on the qualitative variables. So how will you be approaching to measure the safety in your ICU? So in the first one, it is do act cycle. For improvement model, problems are identified, plans are devised to correct the problems, and the plan's effectiveness is assessed. So you have to plan it, do it, act it, and cycle. Now the second method is a monitoring system that detects problems and evaluates them periodically utilizing the quality indicators in your ICU. So these methods are usually utilized concomitantly to balance the two to assess, monitor, and deliver quality healthcare. So these are some of the things that you have to use in your exam so that the examiner would know, yes, you have heard about these terms previously, not very foreign words. So that's the reason why I have taken the sentences just like that to like get you accustomed that plan, do, act, cycle. Famous dialogue in that 12th fail, restat. Okay. Now, this is how can patient safety be ensured. They may ask you that in your hospital, in your ICU, the patient safety is a concern, and your hospital administration has asked you how you are going to improve the patient safety or ensure that the patient is in safe hands. Can you like enumerate? So answer should be from this table. Checklists, pre-operative and anesthesia checklist. Just example, bundles and intervention in your ICU. If your BAP in like rate is very high and patient is not safe, maybe you can implement bundles like very religiously, and you have to do some interventions what you are getting from your clinical audit. That include head of bed elevation, sedation vacation. We all know the BAP bundles, so you can just start singing in front of the examiner. Now, infection control measures. How you can reduce the infection like rate in your ICU? Hand hygiene, barrier precautions, training and education. Like I am trying to give you the like the list of the indicators that you can say. Procedural precautions. Like in your ICU, out of 10 central lines you are doing, patients are having pneumothorax. So in that, the patient is not safe. Maybe the 11th time when you are trying to do, your patient is not in safe hands. So how you are going to improve that? By doing real-time ultrasound. For some of the adverse drug events, clinical pharmacist documenting the patient preferences, medication reconciliation, practices to reduce radiation exposure from fluoroscopy. So these are some of the examples that I want to share with you that you can answer in your real exam. Now, what are the types of error? The examiner may ask you, what are the types of error can happen? So errors can occur at any stage of patient management, including diagnosis, treatment, and prevention. There are two types of execution errors. One is error of commission, and next one is error of omission. So errors related to medication and procedures or the ICU environment are considered the types of medical errors and adverse events. Then they may ask you what you can do to reduce errors in your intensive care units. Just remember this slide. Teamwork, job satisfaction, perception of the management, safety climate, working condition has to be better, and stress recognition has to be better. If your nursing patient ratio is really in bad shape and the nurses are committing the mistakes again and again, then definitely stress recognition and job satisfaction teamwork climate, safety climate, everything comes into place, right? Working condition also. So these are some of the like dimensions to reduce errors in ICU. Now, quality indicators in ICU, I have already told. They may ask you what you can do. You can give example of mechanical ventilation, sedation, medication errors, IV lines. I'm just skipping this. You all know. You can give example of first of BIDS. That is also the quality indicators in your ICU that you can answer. And if you are implementing this judiciously, religiously, definitely your the quality indicators would be improving. I'm just skipping this. Root cause analysis. They may ask you, you are getting some of the adverse drug reactions. How you are going to address this? So you have to tell about RCA. These are the some of the terms that you should remember. They would say you, have you done any RCA? Anybody who has done RCA or know about RCA? Anybody? So this detect the causes of errors and solutions to prevent their recurrence. So this is mainly aimed not to punish, rather you have to get the idea where were the problems, who were the people who actually have done this type of like mistakes. It's not about punishing them, rather it would be getting some idea how we can prevent the recurrence. There are 5 ways to perform root cause analysis. Just remember, they may ask you 1 or 2 ways. One is Pareto chart, the 5 whys, fishbone diagram, scatter diagram, and failure mode and effects analysis. Not going to detail, just remember the RCA. And they may ask you some of the rates, how you will be calculate the collapse rate, how would you calculate the CAUTI rate, how you would be calculating the prevalence of RSA in your ICU, readmission rate in ICU. So you have to just give them the correct formula. They may ask you. Ventilator utilization ratio, number of ventilator days by number of patient days. Some of the examiner who are like into the administration as well as the like the management, they would be asking about this type of question. ICU mortality, hospital mortality, bed fall rate. So these are some of the. Now coming to the last part, legal and ethical consideration. So legal and ethical consideration is some of the questions that the examiner would definitely ask you, not only in the table but also in the long case, and they may ask you in the short case as well. So the question comes like this. Can you discuss the key legal and ethical considerations involved in making end-of-life decisions for patients in critical care? I want one answer from like each one, at least 5 answers. Can anybody tell me? I want only the terminology.
Futility of
Which one? Sorry.
futility of care.
Okay.
Shared decision.
Please start talking. Yeah. Sorry.
Shared decision making.
Yes. One more.
Advanced
This is a question you will
directives.
be asked definitely. Yeah. Yeah. Tell me. Third one.
Advanced directives.
Okay. Good. Any other?
Doctrine of double effect.
Beneficence, non-maleficence, justice, these have to be followed.
Yes, yes, yes. Yes, good.
Autonomy of the patient.
Anything? Sorry?
Autonomy of the patient.
Autonomy of the patient, yes. Then?
Bereavement support to the family is very important.
Yes. Yes. So united we stand. So in the examination also you need everyone's help to answer it completely. So, but again, this is a favorite question, a pet question. You would be definitely getting some or other type of similar questions in your exam. I'm just again highlighting, giving you the terms. Just try to remember. You know the meaning of that. I'm not going into detail. Patient autonomy, everybody knows about. Why it is important? Patient or relative can refuse of sustaining treatments if the disease process is like that. Advance directive, one of you have already told. Legal instruments like living wills, durable power of attorney, you have to know. Informed consent, again, very important, legal and ethical for any of the procedures, any of the interventions that you are going to do. You have to explain related to the benefits, the risk, and alternatives to the proposed treatments. You have to explain, and ethically and legally, this is very essential. Best interest standard. So whatever, when the patient is unable to make decisions and lack advance directive, so whatever you are doing from the clinical side or as a clinician, it has to be done in the best interest, considering you have to again look into so many factors like patient's personal values, quality of life, and likelihood of like the patient to be having like better life. Then legal framework and compliance. It's not always emotion that plays in your ICU or in your healthcare. So that's the reason why you have to also accept or adhere to the relevant laws and regulation. So generally, this includes do not resuscitate order, withdrawal of life support, and euthanasia. So you have to again respect your own like country or state or like a hospital policy. Now, 6.1 is palliative care and pain management. That is again legal and ethical. You have to relieve the pain in your patient. And again, when the patient is not improving, defying all whatever you are doing, patient is not like showing any signs of improvement, then palliative care plays a major role in the like ethical way. Then you have to respect and you have to take into consideration the family and surrogate decision makers. Now, conflict resolution. There would be many times your like patient's family, there would be disagreement family members, and there would be medical staff, or there would be ethical dilemma what to do. So that also is cultural and religious consideration. You have to be sensitive to the cultural and religious belief of the patient and family. So that is also, it is very relevant in the end of life care. And finally, you have to be transparent. You have to maintain everything in your care transparent. And also you have to document whatever you are deciding, whatever you are discussing. And you have to also document all the consent in the language the patient and the family best understand. And also in the language which would be again important to show in case there would be any medical legal issues. So these are the 10 things. If the examiner is asking you, can you explain the legal and ethical considerations that you should be applying in your ICU? So you can mention at least 5 to 7. Now, as you have also told about the principles of healthcare ethics, non-maleficence, autonomy, beneficence, and justice. So you all understand the meaning of that. So you have to, in the exam, you have to just, it has to be from your tip of the tongue. Don't take time. Otherwise, what will happen? The ethical is something like, again, they will be emotional, the examiner. They would be saying that this doctor doesn't know the ethics in the clinical care or the critical care. How this doctor will be a safe doctor, or he will be or she will be a consultant and taking care of like the patient and the family interest. Then they may ask you how you apply the principle of ethics in the patient care. So you can just tell about this terminology and some of the uses or utility. Beneficence, non-maleficent, how, clinical assessment, nature of the illness, goal of treatment, something or other. I'm just giving you the answer how you are going to like defend your like the understanding to the examiner. Beneficence, non-maleficence, respect for autonomy, distributive justice, something like that. So you have to explain about these 4 bio principles of ethics. Now, one question you all know, which of the following is one of the 4 elements of informed consent? All family members must be informed of the options available. Physician must document that the patient has the capacity to decide. The patient must sign a legal consent form. The legal consent form must be signed by a witness. What should be the answer?
D.
Which one? D.
D.
B.
D. D.
D for Delhi.
Yes, sir.
The legal consent form must be signed by witness. This can be. What about A? All family members must be informed. No, only the close relatives. Yes. Okay. So they may give this type of questions as well, just to check whether you are actually up to understand or you are already like witness this type of clinical scenarios. Now this is, you can just read: unconscious accident victim, hypotension from intra-abdominal hemorrhage and needs an emergency laparotomy. His identity is unknown, no family is available. Which of the following should be done? Nothing. It is illegal to operate on a patient without consent. The surgeon should document the need for surgery in the chart and proceed. 3 doctors he should invite, he should call some of his colleagues from some other hospital, should document the need for the surgery in the chart, and surgeon should then proceed. Then he has to appeal or like call or like apply to the court for a order that surgery should be obtained prior to proceeding.
B.
B for Bombay. Perfect. Now, third question, just to check whether you are all aligned with me at this point of time. Patient with carcinomatosis is requiring large amount of morphine. Here, pain is very poorly controlled, and pain service in your hospital feels he will need at least 20 milligram per hour of the for the adequate control. The pharmacist, immediately you have ordered, the pharmacist has checked the order, and he or she is calling you that this is something very high and it can cause respiratory arrest. Now, the appropriate course for the action is
Keep the order to 20 milligram.
cancel the order, continue with our previous dose,
C, sir.
compromise by increasing the dose, keep the order of 20 milligram per hour, change to bolus morphine from the PCA.
C, sir.
E.
C, sir. C.
D.
C. D for Delhi. So you have to change the
C.
bolus morphine from the PCA. Okay.
C.
What is the answer? Can anybody be confirming it?
C.
Answer is double effect. Can anybody tell me what is the meaning of double effect? Here the principle of double effect is applying.
You should.
That means if you are not giving, yes, you have to alleviate the pain. You are not thinking about the respiratory depression. So both the two things are there in your mind. Anyway, patient is in end stage. So you cannot like allow the patient to be suffering from pain. Now, initiation of morphine drip for palliative care. What type of ethical issue? Tell me. Double effect, beneficence. Which one? Sorry.
Double effect.
Double effect.
Double effect would be more appropriate. It would be also beneficence because you are anyway alleviating the pain. So you are benefiting the patient. You are trying to like take care of the patient's best interest. Now, one more question related to communication because next would be final would be communication. 36-year male, they would be giving you this question straightforward. RTA arrives to your ICU after intubation. Initial management from the ER has been done. Despite the best efforts and everything being done perfectly, patient dies within next 3 hours. And you are there in the ICU. You have been asked to go and inform his wife and 2 children who are waiting anxiously in the busy waiting room. Can anybody tell me? This is a real question. In the communication table, they may ask you. They can also ask you in the long case or in the short case. Can anybody tell me how to approach? I am waiting. It would be 2 minutes time I am giving to all of you. Anyone wants to approach with a structured way? Anybody who is trying? Anybody who is trying?
Maybe have blue brand and
Dr. Pankaj or Dr. whoever is talking, please mute your like speaker.
Sir, I would like to first have a comfortable setting, in comfortable setting. Then comfort physical and psychological setting of the wife. then ensure the patient's the relatives' viewpoints, sir. Build a better doctor-patient relationship. Prior to it, I would like to first greet and introduce myself. Offer her water and comfort her. Just open the discussion. Explore the patient and the family understanding. Spikes protocol, sir. Short.
Can anybody tell me what are the the full form of spike protocol?
Sir, setting, perception, invitation, knowledge, emotion, and summary.
Okay. Okay. So can anybody tell me what is bad news?
Bad news is anything
I'll be
that
taking.
disrupts one's perspective about the future.
Yes. Good. Any information that drastically alters the life world of the patient is termed bad news. Also, you can answer any information which adversely and seriously affects individual's views of his or future. And conveying bad news is a skilled communication. It's not a just simple way and you are going to the patient's relative talking about that yes, your patient is dead now and I am the doctor and I am supposed to inform you. This is not the communication that is expected from a seasoned intensivist like you. Now, what constitutes bad news? Can you give me some of the examples that are termed as bad news? Is telling that your TLC count is 28,000, yesterday it was 15,000 is a bad news?
Unexpected death, non-recoverable malignancy.
So everything which with a proper structure. So you can just go through these lines: unfavorable diagnosis, irreversible, untreatable, unstoppable disease, side effects, complications, disease has recurred, spread of disease has happened. You have thought of the pleural tapping to a so it is a pneumonic effusion, but surprisingly it is showing malignant cells and patient is right now having metastasis to the lungs. So these are some of the examples that you can give. End of life decisions, death. So revealing some of the tests you have sent and the result has come surprising to everyone, to the clinicians also. Then why we should break the bad news? Why we should break the bad news? We can keep the bad news with us. We will be only sharing the good news. And when there is something which is not appropriate, we will be hiding or we will be not informing. Anyway, the patient is going to get it through the lab reports or some of the the nurse will tell. Why the doctor would break the bad news?
To open it in a comfortable way and make understand.
Again, this is everything is with a structure. So you can explain in this way. From the ethical point of view, yes, autonomy. I have to respect that, yes, I have to inform the patient whatever has happened. Beneficence, I have to inform for the patient's benefit. Non-maleficence, I have no other interest of harming the patient by hiding the things. Professional, as a professional, I have to be a communicator. I have to advocate the patient's rights to know the lab reports, the disease condition. And also I have the duty to care. And in that, I have to inform the good news or bad news to the patient's relative in a proper way. Third point, human rights. Everyone has the right to know what is happening to the family, whatever is happening, to decide also. If I will hide the thing, maybe the family doesn't want to continue with the treatment. They have to quit treating or putting the patient on ventilator. So if I will be not informing or breaking the bad news, that would be definitely not a good sense to continue like this in your ICU. Then fourth point would be legal. If I am not informing or breaking the bad news, maybe the family relatives will sue a case of negligence. End of life care decisions I am halting. I am not allowing the end of life care decisions to happen. And also maybe there would be some of the advanced directives the patient or family is having. So I have to inform them, then only they will like show me the advanced directives. So these are some of the things that you have to answer in your exam. Then they may ask you something like this. How can you like explain the grief and loss model? What do you mean by Kubler-Ross model? So it is Daniel. You it will be like informing the bad news. There would be a like a situation when the patient or like the family, they would be starting to deny first. Then there would be anger. Then there would be depression, and then they would be bargain with you. Doctor, it cannot happen. Can it be done in some other way? Can you help us? Can you like do something miracle? And finally, when you still continue to like explain that this patient is not going to improve, or this is something which is very bad fortune for the patient, then they would slowly go into the last phase, that is acceptance. So this is something you have to remember. Then goals of the bad news, we all know, maybe they would be like getting to know that whether you are knowing the goals of bad news. I have already explained to you. Then straightforward, they would ask you, can you tell me some of the protocols that you should apply in your day-to-day communication, like sessions or counseling room? So this is spikes. SPIKES. Everybody knows it. I'm not going into detail. They may be very fond of asking, apart from spikes, can you tell me anything other than spikes? So for that also we have answer. We have answer for everything. So you can go with also, I have like a better to remember ABCDE. Like for everything in critical care, you can start with ABCDE. So here also ABCDE. Advanced preparation, build environmental relationship, communicate well, deal with reactions, and ease, encourage, and validate emotions. And finally, breaks. Background, rapport, explore, announce, summarize. Spike protocol, everybody knows it. Just remember, they would ask you, and if you start with the meaning, then they would understand, yes, you have at least counseled your patient or have studied it well, and you can summarize it well. So I'm not going into detail. So with this, I'm on time finishing. So maybe 5-7 minutes late. So any questions at this point of time? I've tried to summarize everything that can be asked in this table. This is a table, no man's land. So you will get anything and everything in this table. Okay. So with this, we come to end of the second session.
One question.
Now yeah, please.
Sir, regarding withdrawing from the ventilator, where are we in terms of Indian law? Can we go ahead if there is a futility of treatment, and also the patient relatives want the patient to be disconnected from the ventilator?
These are some of the very controversial questions, and legally, I think you should not comment upon some of the Western guidelines, what they say in our Indian exam. So still in our India, it's like you are not supposed to take the tube out. Maybe like with the family relatives, like the wish, and also some of the like notary notification, you are informing to the district magistrate, and the patient is like the actually having irreversible disease and deteriorating, and there is no chance of clinical recovery, and that is not only being treated by you. There is a team of doctors, they all feel the same thing, and preferably one doctor from some other hospital if you are going to take the decision of taking the tube out. So you can explain in that way, that would be politically right. But if you will be straightforward, say that as for the family relatives request and the patient is not improving, I will decide to take the tube out. So that may not be a political right statement. In the examination, better play safe. Right? I think you are getting my the point, what I'm trying to say.
Sir, I have a question.
Which one? Sorry. Yeah, tell me.
Patient is confirmed of having brain death. Brain death examination apnea test is positive, and relative now don't want for organ donation. So, and also they don't want to get patient off ventilator. Means they don't. We have counseled them that it's equal to the death, and if you don't want to donate it, then it is like circulatory death. But they want to continue it on the ventilator. So how to?
Dr. Ritesh, you have told something which would very I can say the examinee or the clinician would be deep trouble if he or she would be counseling to the family that your patient is brain dead, so you have to go for organ donation. Why I'm saying? First of all, the treating clinician should not be part of any organ donation process. Are you getting my point? You are part of the team, you are treating, and you are till the time that patient is brain dead and not improving, you are okay to inform to the patient. Once you are thinking that this patient is brain dead and patient is a potential candidate for organ donation, then instead of you going to the family relatives and calling them in the counseling room, talking about that, you have to go for organ donation, otherwise actually there is no point of continuing. That would create so many medical legal problems. I hope you are understanding. They would feel that you are not very keen on continuing to treat, as you are getting a patient or a person with so many organs.
Yes.
In every hospital, organ donation or organ transplantation is actually very active. So it's a team of the transplantation or the counselor, the transplant coordinator. So he or she has the responsibility to identify, yes, these are some of the patients who are the right candidates. They may be selected for organ donation. They will start initiating the discussion with the family, not you. That is point number one. This is a very important question. The examiner may also create this type of scenario that your patient is not improving, patient is brain dead. Can you start discussing about the organ donation with the family? No, don't trap into that, the scenario they are offering now, the examiner. So if you are telling that, yes, I will go and start talking about the organ donation straight away, maybe it is not the right way. Point number one. Now, second point, if your social counselor or the coordinator, transplant coordinator is going and discussing about the organ donation, but you cannot and they are not agreeing. So there is a situation where the patient relative is not agreeing to take the tube out, or they are forcing you to take the tube out. My point is right.
No,
Your question.
Relative wants that we want patient to continue
The
on the ventilator.
care to be continued. Okay. So in that case, what your answer should be, you should have a medical board. Okay. And patient is continuing without any problem. There is heart rate is stable, everything is okay, and only the patient's brain is not working, brain dead. So you have to take a decision if it is taking, the patient is perfectly stable, otherwise, and it is taking one of your resource, your bed is occupied, your ICU bed is not being utilized for a needy patient. In that case, with the medical board permission, and you have to inform to the district magistrate, and you can make a situation that you have to take the you have to reduce the ventilatory support, may not be directly taking the tube out, which would be make the family may complain or file a case that you are going for active euthanasia. Rather, you can reduce the support, then try to end with a dignified manner the life. But it has to be medical legally right. That is the whole essence. And it has to be with a medical board.
But then, sir, without telling the family, can that be done? Like a reduction of 27?
I know. Where you are going. We all know that, but yes, you cannot document this or answer or tell to the patient's family or in the examination that hidingly in the night time I will tell my junior to just reduce the FiO2 and put some water in the syringe pump instead of noradrenaline, and make the patient in the CPAP with FiO2 of 0.21 with PEEP of 0. Are you getting my point? I totally agree with you that yes, there are many other ways to go for the end of life care, but this is not the way we should be doing. If you are doing it, but it's not having the proper legal perspective, in Western countries, if you're doing this type of thing and some or other person is knowing or get to know this, he or she can like sue you.
Right, sir.
Right.
Right, sir.
Okay. Thank you, all of you. And with this, I invite Dr. Vishwa Vikas. Are you there?
Yeah.
So Dr. Vishwa Vikas is consultant and head Utkal Hospital, Bhubaneswar, and he would be discussing about one station. I think not a bland topic like myself, rather it would be like everybody is doing day and night, assessing the clinical lab findings, then going through the radiology like CT and X-ray. So he would be discussing in depth about this important station. Over to you, Dr. Vishwa Vikas.
So very good evening. Thanks, Dr. Tapas. So basically, Dr. Tapas was taking a very difficult topic. My topic is a little bit easy for you. So he took the topic in such a nice way. I was listening in the last 30 minutes. So thanks, Dr. Tapas. So basically, my session is radiology and lab investigations. So remember, these are the topics where we'll fetch marks, because some may be good in statistics, some may not answer in quality, all these things, but you have to answer radiology and lab investigations, because these are the scoring. Because here, if you will do very well here, your pass rate is 100%. Okay, so without wasting time, so we'll start with radiology. Okay, so remember, in every exit exam, these are the common topics like chest X-ray. They may give you some abdominal X-ray or not, but chest X-ray is a must. And ultrasound. Nowadays, ultrasound of chest, abdomen, optic nerve sheath diameter, DBT scan. Nowadays, emerging topics. So nowadays, they are more focused in ultrasound rather than X-ray and echo. Also, to some extent, they will go to the CT scan. Mostly, they will touch CT scan of the brain, chest, abdomen to some extent. And some old examiner, they may ask you regarding cervical spine X-ray, especially trauma patient. I will touch upon the MRI brain, because maybe some of you get some typical MRI brain relevant to critical care specialist, not like an neurologist. They will go through the tumor, everything, but some like relevant to critical care, you may get MRI brain. At least what is MRI brain, what are the sequence, everything, that I will touch. But these two things like ultrasound and echo, as it is emerging topic, that's why we kept it separate, because these are the things when we are appearing DNB exam in 2000 maybe 13-14. So that time it was emerging, and we are getting every alternate students are getting ultrasound of the chest. But nowadays it is very common, and everybody will face ultrasound and echo. So we people must be thorough about ultrasound and echo. Okay, I think that has been discussed. So straight away we'll go to the chest X-ray. Everybody will get a chest X-ray. Remember, though nowadays you go to ultrasound, but we'll get chest X-ray must. That's why to describe chest X-ray, we should have a very systematic approach. And remember, interpret chest X-ray in conjunction with clinical finding. Though you may not get a clinical history in the when in the exam, but if somebody is giving you some X-ray and you are able to see like it is a pneumothorax, and somebody some examiner may they give you some clue. That's why always in your clinical practice also interpret chest X-ray in conjunction with clinical findings. Always compare with previous X-ray if available, and ask yourself, does my interpretation make sense? Okay, so say in the intensive care setting, because routine chest X-ray in the radiological department is PA view, but in ICU chest X-ray is AP view. Patient always in the supine position. That's why you should remember the difference between PA view, AP view. Though I know every now as you are appearing the DNB exam, so everybody know the difference between PA view and AP view. So they may, somebody like old examiner, they may ask you, so what is the difference between PA view, AP view? But you should remember, just go through what is PA view, what is AP view. So like what are the difference? You should remember this, okay? So what are the problem with ICU chest X-ray? Here the magnification of the anterior structures like clavicle, sternum and heart. In supine position, there will be widening of the mediastinum and heart due to gravitational effect. That's why this ICU chest X-ray is something different from the routine chest X-ray, which we do in the OPD department. Now, comes to the important topic, how to read chest X-ray. So before reading any chest X-ray, this is the scenario, every step. So name and date, view, AP view, PA view, lateral view, whether it is centered or not. Like what is centered? So that means your right and left sternoclavicular joint is equidistant from midline or not. That is, this is well centered X-ray or not. And the fourth one is the exposure. So that means well exposed or overexposed or underexposed or exposure is perfect. And which part of the respiration, whether it is inspiratory film, what is expiratory film, that also we should able to differentiate. That somebody maybe ask you if whether it is an inspiratory film or it is expiratory film, what is the difference, whether it is over penetrated or whether it is under penetrated, that we should able to answer. Otherwise, sometimes they may not have time to ask this, but we should, before going to exam, we should remember this. Okay. So when we will answer the chest X-ray, we should remember which are the parts we have to be focused. Most important in the lungs. See, in the lungs, like parenchyma, you have to go through like consolidation, pulmonary edema, effusion, collapse, all these things will go through. So here the lungs. Another is between the lungs, like heart or mediastinum, we have to comment. Outside the lungs, like pleural fluid, pneumothorax, refracture, surgical emphysema, subcutaneous emphysema, that also you have to comment. And what are the common devices like endotracheal tube, nasogastric tube, central line, drain, pressing, IBP, all these things. Any X-ray, if you will get it, we have to remember, you have to answer with all these things like whatever the lungs, between lungs, outside lungs, what are the devices, all these things we have to answer. So these are the like common exam questions. Like they will, if somebody asks you chest X-ray, they mostly ask you with this, like abnormal position of the line, like central line position, like IBP position, all these things. And in the long parenchyma, they will ask you ADS, consolidation, collapse, pleural effusion, and pneumothorax, hydropneumothorax, sometimes foreign body. If sometimes very typically like they may ask you hiatus hernia, all these things like, but the common one is the long parenchyma, barotrauma, effusion, line, all these things will go through. So we'll go through the questions only, okay, so that it will be a revision type for you, because now after 7 days you are going to appear the exam. Mostly you have gone through the like yeah, but this is a practice type, okay. So we'll show you the questions. If somebody is interactive, you may answer, otherwise we'll discuss, okay. Case number 1. So it is a 48-year male patient post Whipple surgery. We received the patients 2 hours later in the intensive care unit. Immediately after receiving the patients, there is decrease in saturations. Immediately we have gone for a chest X-ray. This is the chest X-ray. Can anybody comment anything on the chest X-ray?
It's a view, and the left side has been collapsed. The trachea has been
Right.
the left side.
Endobronchial intubation.
Yeah. Excellent. So So the basically here actually right endotracheal and endobronchial intubation, and the your left lung is getting collapse. Okay, so your answer should be in these pages you have to AP view. This is the lung, this is the right endobronchial intubation, and the left lung collapse. That is your answer. Okay, so then they will ask you what will be the ideal position of the endotracheal tube. So, what is the maximum distance above the carina? What will be treatment in these cases? So it's not like that only thing they will give you the X-ray, identify this X-ray. So after you are able to answer these questions, identify the problem, they will ask you the side questions like if it is collapse, what will do? So we'll remove the tube, we'll go to the like chest position. Then if it is not there, if you'll go for bronchoscopy, all these things they will ask you. But first is identification. If you able to identify, then they will go to the next question. This is the second question. This is a 60-year-old female which arrived in the hospital with a large right pleural effusion, which is stabbed and discovered to be tuberculosis. A chest tube was placed to drain the effusion, and you have advice for a chest X-ray post ICD incision, which is there. Anything? Any comment?
Chest tube is outside the pleural cavity, sir.
Excellent. Anything else?
Subcutaneous.
Yeah, very good, very good. So basically, the chest tube is not functional. This is your first answer. It is not in the pleural space, but rather in the subcutaneous tissue. And there is some air in the subcutaneous tissue that you can maybe tell you subcutaneous emphysema. And but you remember, still you have to answer that there is large right pleural effusion with some part of the compressive atelectasis is there, because here this part is already your effusion is there. Okay, that you have to answer also. And you have to, as I have told you, you have to see any line, anything. Here is a subclavian line is there. Okay, so we have to answer also a central line is there in the superior vena cava. So all these things you have to comment when you are answering. Okay, now we'll go to the next question. Is a 88-year-old male, multi-system failure, septic shock is there in the intensive care unit since last few days. You have advised your chest X-ray at the bedside. You have to comment on the chest X-ray.
Right bronchus
Foreign body in trachea.
Foreign body or something
IP.
else.
Right.
So your nasogastric is coiled and it is in the left bronchi. That also you have to comment. It's not that it is coiled only. So it is going towards the left side of the bronchus. So that you have to comment. It is coiled and it is in the left bronchi. Then if it is easy for you, but remember in your DNB exit exam, you will get any type of X-ray where you can able to answer. It's not like that. It's very like uncommon X-ray something they will give you. You will not able to like identify. You will get this type of X-ray only. Hydropneumothorax. You will able to answer. So they will not give you any X-ray where there will be no finding. They will not give you like that. Then they will ask you what is the correct position. You see, this is the correct position of the endotracheal tube where this will cross the dome of the diaphragm into the stomach. Okay. So now the next question is, it is a 70-year-old known case of advanced glioblastoma multiforme, now admitted with shortness of breath. So the straightforward question is comment on the chest X-ray, but rather I have mentioned it, comment on the invasive line. Can anybody tell me?
VP shunt lines.
Yeah, excellent. So though I have given you the clue like glioblastoma multiforme, so sometimes you may not get the clue. You got my point? They directly give you the X-ray, but you sometimes it will be difficult for you to comment. As I have given you the clue, so that's why it is little bit easy for you. But sometimes in the exam, it is a very stressful time. You people are going to appear in the exam with a lot of like stuff in your head. So that may be a little bit difficult, but if you are able to answer, it will be very good thing. So it is straightforward. This is a VP shunt, and here the endotracheal tube. Endotracheal tube is the proper position, and the VP shunt catheter in situ. Okay, so this why I have kept this. So you should remember that whatever the possible lines possible, like nasogastric tube, endotracheal tube, central line, tracheostomy tube, all these they will put you in your exam. Now, this is a question: is a patient of cardiogenic shock after drug overdose. So came to your intensive care unit, you have intubated the patient, advice on a chest X-ray. Comment on the X-ray. Can anybody comment on the X-ray?
The ED pads.
Excellent. Any other? See, there are a lot of things. This is the one is the, what is this?
IABP, sir.
I have
No,
given a clue of cardiogenic shock. That means if you are smart enough to this is the IABP catheter, which is malpositioned. Another is the endotracheal tube. Another is the transcutaneous spacer. And your the endotracheal tube position is little bit high up. Okay, you can see that it is maybe a little bit high up, but your IABP position is malposition. Okay,
Left IG catheter is also in situ.
Yes, you can also tell this. But we have to here the important thing is IABP catheter. So the next question will be what will be your IABP catheter, ideal position of the IABP catheter tip. The tip should be within the proximal descending thoracic aorta, distal to the origin of the main branches of the aortic branch, and just distal to the origin of the left subclavian artery. So they will ask you somewhere, they will ask you anywhere, what is the ideal position of the IABP catheter? If it is too low, what will happen? If it is too distal, what will happen? What will be the renal indication, renal failure? Where will the position the ARF will happen? What will happen? The distal. All these questions you may get in the answer. So regarding IABP catheter, we should go through. Okay. Now the next question. It is a 16-year-old male, severe burn, 40% body surface area. Now develop respiratory distress on the second day of admission to the ICU. Comment on the chest X-ray.
There is.
I think this is
But
easy.
it is in both the lung field, more on the right side. Also, we are able to see ICDs on the right side.
Yes, it's not ICD exactly. This is the multiple lines here and there. So basically the long parenchyma you have to comment. This is the burn, severe burn, respiratory distress in the ICU. So basically you have to comment on the first on the line. Here is the one line is there. Okay. Rather here I have not comment here is the another line here, subclavian line is there. But basically the long parenchyma bilateral like multifocal air space opacification mainly perihilar and lower zone. So basically this is a case of ARDS. This patient on high FiO2 on ventilator, post burn. This is the typical of ARDS. Sometimes you may be confused regarding fluid overload, but if you are able to comment on the fluid overload, so mostly it will be perihilar. Though it is, you can see this is the diffuse. Though the X-ray I have taken is little bit like it's not clear, but still it is a case of ARDS. Okay. Now the next question is, he is a 79-year-old man, 48 hours of cough, low-grade fever, right side pleural effusion, pleuritic chest pain, and what is the comment on the chest X-ray? What is this?
Westermark sign and right because of pulmonary embolism.
Why Westermark sign?
No.
Why you are going for so your diagnosis is going for pulmonary embolism?
Right side middle lobe pneumonia.
Yeah, exactly. So always go for the common answer. So this is basically airspace shadowing and air bronchogram in the right upper lobe. This is a community acquired lobar pneumonia, nothing else. You can see So basically, this is a lobar pneumonia, especially if you right overlobe involvement. So mostly in these cases, you will get the organism is Klebsiella. So basically, here the history is old man, fever, cough, and this pleuritic chest pain. This is a common thing. So this is community acquired lobar pneumonia. So always think the common one. Don't go to the uncommon answer first. Okay. So now it is a 48-year-old in severe respiratory distress and is intubated on arrival at the emergency. And there they have gone for a chest X-ray. What is this chest X-ray?
Left-sided dense opacity.
Exactly.
Involving
Left-sided.
all the
Left
left-sided
lung
collapse.
whiteout, left lung whiteout, complete maybe collapse, or
Exactly.
secondary to trauma, some.
Very good. This is a complete collapse of the left lung. There is no air bronchogram and trachea is deviated to the left, and your right heart border, even you can see your right heart border is not visible. That means mediastinal shift is there. And they may ask you, if you're telling that this is a collapse, they may ask you what will be your line of management. You can make position of the patient, then you can go for a bronchoscopy. Like that you have to answer. Now the question is, they may ask you what is the difference between collapse and consolidation. It's a very favorite question of all examiner. So you have to remember what is collapse, what is consolidation, what is the difference. Even in the X-ray also, they will ask you this type of like a clinical question. So like volume loss, ipsilateral shift of the mediastinum, no air bronchogram. So here consolidation, there is no shift, air bronchocolumn is present. All these things difference, you have to at least 2 points you have to answer. Okay. Now we'll go to the next question. So this is a 41-year-old male, motor vehicle accident 30 minutes ago. He's alert, complaining of severe chest pain, and immediately you have advised for a chest X-ray. So what is the comment on the chest X-ray? I think it's easy.
Left pneumothorax.
Anybody want? Yeah. So not only left pneumothorax, you have to answer this in the format of left pneumothorax with your shift of the mediastinum. You can see this is mediastinal shift is there. That's why you have to call this is tension pneumothorax. Okay. So when your mediastinal shift is there, massive pneumothorax, you have to utter the word is a tension pneumothorax. Then they will answer, because if you go to tension pneumothorax, they will ask you what is your immediate management. Okay. Now you have to remember pneumothorax.
Sir, that comment on tension pneumothorax, you don't have the hemodynamic parameter.
Sometimes even that's why if you are smart enough, you ask the question to the examiner. So may I know what is the clinical condition of the patient?
Right.
See, that's why in my first slide I've told you, only on the radiology you cannot comment. Sometimes we have to ask the examiner, sir, may I know what is the clinical condition of the patient? What is the saturation of the patient? Whether the patient was unstable, was not there. So, listen, in your exam, very high chance they will not give you any clue. They will show you only the radiological finding. There you have to comment anything. This is a pneumothorax, left like tension pneumothorax. If they will give some clue like this patient came and this is the sign, then only you have to comment anything. You got my point? So in exam, because they don't have time to give you all this clue, they will ask you question. They will show you 4-5 X-ray, but they will show you first, because they have to show CT scan. They may have to show the MRI. They may have to show something else. So maybe within a span of 5 to 10 minutes, you will get 5 to 10 radiological questions. That's why they may not give you clue. But if you're smart enough, you will ask questions. Okay. So in the pneumothorax, you should know the difference between skin fold and the pneumothorax. This is some examiner, they may ask you what is the why it is not a skin fold, why it is pneumothorax. So this difference you should know. Okay. So how will you differentiate between the skin fold and the pneumothorax? Can anybody tell me? So basically here, see, here is a is a mark. Okay. In the pneumothorax also there is a mark, but the difference is above this distal to this mark, you will not getting any like a pulmonary vessel. But here you can see you are not getting vessel, but you are able to see the pulmonary vascular marking. So the difference between these two is there. Skin fold versus pneumothorax. Now go to the next question. Like 73-year-old male, female, presented to our emergency department with severe anterior chest pain. The portable chest X-ray was like portable film was obtained. What is the finding on the chest X-ray? Can anybody comment?
Pleural effusion left.
Left side pleural effusion. Any other comment?
Wide and mediastinum.
Okay.
CT.
Okay. So what happened for this patient? This film was interpreted by the emergency department physician to show an elevated left diaphragm with cardiomegaly. But the radiology suggests that this configuration represents a large ventral hiatus hernia. So we have gone for a CT. CT shows a good portion of the stomach in the chest. So see, this type of X-ray is very uncommon. But if you are very like unfortunate, you may sometimes get this type of questions. But this is unfortunate, which is defining. But this common thing is you can tell that this is a pleural effusion is there, like cardiac border is widening of the mediastinum. All these things, what you people are telling, this is correct. But in this case, this is a typical case of large hiatus hernia. So this is a 79-year-old female with a history of atrial fibrillation and hypertension present with increasing history of dyspnea. This is the chest X-ray. And this same patient, 2 weeks before, he came to the hospital, and that time one PTCA was done, and that time the chest X-ray was this only. This is the present chest X-ray. This is the chest X-ray 2 weeks before. Can anybody comment anything?
Bronchovascular markings are prominent.
Okay. Any other?
Wide and mid.
From right side.
Okay.
Mediastinum.
Okay.
The
So
of aortic knuckle and depression of left main bronchus.
okay. So same patient, you can see this is the before X-ray. This is the present X-ray. The cardiac cylinder you can see here. Now looks bigger and more globular. You can see this is the cardiac. Now the cardiac shadow you can see. Now anybody comment anything? Excellent. So this patient 2 weeks back has gone for the post procedure. AF was there. Now AF was there. That time PTC was there. Now this heart is globular. Mostly some this type of like this patient is developing pericardial effusion. So pericardiocentesis was done. 300 ml fluid was removed. Now you can see this post procedure. The cardiac shadow again normalizes. Okay. So this is another question. This is a 45-year-old lady present with fall, productive now, presenting with history of fall, now presenting with productive cough, fever, and dyspnea. Comment on the chest X-ray.
Left side left chest there, sir.
Okay.
Left pleural of pneumonia.
Left
good.
Thorax.
Left rib fractures with left hemothorax.
Okay. So basically, there is marked tracheal and mediastinal deviation to the left. You can see, okay, reflecting collapse and volume loss of the left lower lobe. Fracture of the seventh rib. Okay, though it is not seeing. Here you can see this fracture. Here also, this is not clear, but here the fracture of the both side, the fracture rib is there. But air bronchogram in the left mid zone also there. If somebody is telling that there is some consolidation, exactly there is some like he has a trauma followed by this log is getting secondary infection, so it is consolidation. And if you're smart enough, you can see there is a small apical pneumothorax is there. Okay. So these are the finding, but if you are able to answer something also, so you'll get good mark. But somebody is telling like fracture is there, collapse is there, and small pneumothorax is there, then it is enough if you are able to answer all these things. Okay. So maybe this one, the last questions of radiological. It is a 30-year-old male presented with a 24-hour worsening of respiratory distress following a 5-day prodrome of cough, fever, diarrhea, lethargy, and malaise. So a chest X-ray performed 12 hours after intubation is shown. What is this chest X-ray? Yeah, excellent, excellent. So if you are able to answer this type of questions, so you'll get excellent marks. So basically, this is supine epithelium, endotracheal tube position is a little bit high. You can mention it. It a little bit high in the trachea. Bilateral diffuse opacities are there. There is pneumomediastinum. So basically, here the examiner will want to listen whether you are able to utter the word pneumomediastinum is there. Got it? Okay. So, and the nasogastric tube, here the nasogastric tube is there, but after that, where it is gone, it is not. So basically, the gastric placement of the tube is cannot be but gastric placement is not can be commented. Okay. So this is pneumomediastinum. Okay. So this is a routine chest X-ray of a 34-year-old male during health checkup for his new assignment. So can you comment on the chest X-ray? Yeah, very good. This is a dextrocardia, but sometimes also in the exam they may be give you this type of question also. So only dextrocardia or something else? Somebody can comment anything?
Liver also, opposite side.
So basically, the heart is on the right side, depending dextrocardia. Cytos inversus is present. So basically, you can see this gastric bubble is also on the right side. Okay, so basically, cytos inversus this patient who is presenting celiac abnormalities like dextrocardia. So we want to hear the word whether you are able to mention this heart is in the right side going to the dextrocardia. So this is the last question. So 60-year-old lady with
left side and right side are not mentioned. So can it be the X-ray revert if you see?
Exactly. If so, basically, if you will able to get X-ray, usually they will mention where is the right, where is the left. Though it is not mentioned here, you may always ask the question, sir, why it is not a left side? What you are ask me like that, you have to question, because every time if you will get a chest X-ray, they will mention which is left, which is right. As it is not mentioned here, so it is correct. If you are, it is not mentioned in the exam, you will get X-ray. They will show you which is the right, which is left. Okay. Always they will get you. Next question is 60-year-old with COPD, bronchiectasis, present with severe abdominal pain and breathlessness. Comment on the chest X-ray.
Even diaphragm is left side higher.
Even the gastric shadows are saying gastric distension.
Yeah,
Maybe
gastric distension. Okay, anything else? But what is this?
They are under the
Yes, yes, excellent. So there is air under both the hemidiaphragm, suggesting a perforated viscous. So basically, this is visible here, though it is not visible, but it is visible here. So basically, this is a hollow viscous perforation air under the diaphragm. Okay, though if you are smart enough to answer this, basically this bowel is dilated, though maybe some perforations, everything, but this is air under diaphragm. Okay. So, so basically, these are the X-ray I've shown you. So like parenchyma, lung, like lines, like barotrauma, like pneumothorax, like pneumomediastinum, and like all types of like IBP, Ralph's tube, central line, all this line I have shown you. So these are the common topics in the chest X-ray they'll ask you. Okay. Now we'll go to the CT thorax and abdomen. Okay. So in the CT thorax also they will ask you consolidation. Mostly they will ask you like pulmonary embolism, aortic dissection. In the abdomen they'll ask you pancreatitis, bowel ischemia, if cholecystitis, and like a common thing, because abdomen CT interpretation is not the job of an intensivist, but sometimes as you are appearing the exam, they will ask you some questions. You have to know like if you are on duty in the middle of the night and you are suspecting pulmonary embolism, and if you are go for a CTPA, you should remember, you should able to interpret what is the CTPA finding, like especially pulmonary embolism, and you are able to identify what is pneumothorax, identify what it is pleural effusion, and in the aortic dissection, all these things common things. So they may not ask you if like X-ray, they may not ask you in detail of CT thorax and abdomen, remember, but if you are able to answer something, uh, they will appreciate you. Okay, so directly I'll go to the questions. Okay, so basically it is a 54-year-old female. It's a short nurse presented with shortness of breath after a very long air travel. So as you are suspecting like a long travel history, anything, we have gone for a CTPA. Can anybody comment on the CTPA?
Bilateral thrombus in the
Filling defect is saying.
Exactly. Very good. So where is the filling defect? Whether it is the
Segmental.
central defect? Exactly.
Right.
Peripheral
Basically,
segment.
so basically, this is bilateral proximal acute pulmonary embolism involving the segmental branches. It is not in the main branches. If it is the right or left or like main branches, you have to mention this. But as it is causing segmental, you can tell that this is a segmental pulmonary embolism, bilateral proximal acute pulmonary embolism. See, here I have given a clue. I have shown you the city. So for you it will be easy, but if they will show you this type of film, like sometimes they have given, if you see this type of city, like they have given contrast and they are asking something, and if you see some film defect, directly you can tell that this is pulmonary embolism. But for you it will be easy. Okay, so pulmonary embolism, what we found, this is filling defect or vessel occlusion is diagnostic of pulmonary embolism. If there is a central filling defect that spans the main pulmonary artery, where it branches to the right and left pulmonary artery, it is called a saddle thrombus. Emboli may completely obstruct the vessel, or it may be partially obstructive. So you have to remember in the pulmonary embolism, what is the finding. So here is a 70-year-old man, hypertensive, sudden onset, severe chest pain. So immediately I have gone for a CT thorax. What is this?
Aortic dissections.
So see,
Ascent.
on the first look, it's looking, it's it's very easy, but in the exam, they will ask you this type of question. Remember, I'm telling you, they will not give you city finding which is very atypical. They will not give you. They will give you the typical like city pulmonary embolism, like aortic dissection, like pancreatitis, like bowel ischemia, all these things, which is very obvious in the city. They will give you. They will not give you anything which you are not able to interpret, because see, still this is the job of the basically the radiologist. We the intensivist, we should interpret the city which is very urgent, where the middle of the night we are not able to call the radiologist, and the patient is very sick, like pulmonary embolism, aortic dissection, massive pleural effusion, where to put like pneumothorax, you have to insert the ICD. Remember, so it will be easy for you. So basically, this is like aortic dissection in the ascending aorta results from intimal interception between the true and the false dissected lumens of the thoracic aorta. So this is the case number 3. So it is a 76-year-old female present with right upper quadrant pain, and which pain is severe pain, which is related to the back, and it is also the fever and vomiting. Okay, so symptoms had been ongoing for the last 72 hours. We have we have done a CT abdomen as this this is the abdominal finding. Can anybody comment anything on the CT abdomen? That's why I put 4 like cards, so it will be easy for you.
Second right image, bulk and enlarged pancreas.
Okay. Excellent.
Yes,
Any
it's
other?
been able to delineate the borders
Because
along
of
with
pancreas.
there are lots of
Okay, good.
it has
Excellent.
Spleen,
You are telling something.
splenic.
right.
So, okay.
Gallstone
So, in
clearly, ma'am.
yeah, somebody is telling right. It is gallstone also. So the answer is so basically, you see, we are in the comment. You can see hypo enhancement of the body of the pancreas. Okay, here. Okay, with surrounding fat stranding suggestive of necrotic pancreatitis. See, so 2 types of pancreatitis. One is edematous pancreatitis, the pancreas will be swollen only. Another is like necrotizing, where you will see hypodensities. That is called necrotizing pancreatitis. Apart from that, you can see like peripancreatic fat stranding. So gallbladder wall thickening is there. Like peripancreatic fat stranding is there. This is the fat stranding. So apart from that, somebody was telling like gallstone. Here you can see there is a round calculus. This one the large calculus. This is pericholecystric fat stranding, and the GB is distended. So this is cholecystitis. Okay. So next to here, if you are smart, you can see your CBD is dilated. Okay, so though it will be a little bit difficult for us to answer. So here is the dilated CBD with smooth enhancement of CBD wall. Another thing is you can see here also intrahepatic duct is dilated. Here you can see, though it is difficult for us, but see with this clinical scenario, all these things, the CT shows cholelithiasis, cholecystitis, which has caused pancreatitis, and as the CBD is dilated, it is called cholangitis. So the cause of pain and the fever for this patient is pancreatitis, secondary to cholelithiasis, and this some form of cholangitis is there. Okay, so when you get this type of CT scan, so basically you will concentrate first, will concentrate on the pancreas and the gallbladder or some extent of the liver. Okay, so then we'll able to answer. So like don't go to the spleen, all these things. See, for us it is very difficult to interpret the abdomen because we people are not very like sure to comment on every organ, because abdomen is the very difficult organ. Like lot of the things are there, even the good radiologists are not able to comment anything. But for us, as you are going for exam, but you people get very well versed with like pancreatitis, like, well, whatever the common city is there, you just go through. Like sometimes they may ask you pyelonephritis, like all these things, like kidney, you can able to comment kidney, gallbladder, liver, and pancreas, and whether the bowel ischemia or pneumoperitoneum is there. That is enough. So this is the case is necrotizing gallstone pancreatitis, and there is some features of cholangitis. So same patient, 3 weeks after, due to persistent pain, we have gone for a repeat CT. Can anybody comment here? Here you can see.
Wall of necrosis.
Definitely. So this is pancreatic pseudocyst. So basically here is a well circumcised, usually round or oval peripancreatic fluid collection of homogeneously low attenuation, usually surrounded by well enhancing wall. This is called pancreatic pseudocyst. So we should remember what is the features of pancreatitis, what is the edematous pancreatitis, what is necrotizing pancreatitis. Okay, so this is the CT feature. Now to the question number 4. So this is a 70-year-old hypertensive now present with severe abdominal pain for 4 days. So on examination, there is tense abdomen and feculate vomiting is there in the RALS 2, and in the BG there is high lactate. Okay. So for you. So with this clinical scenario, we are able to answer this. Anybody comment anything? So basically, large of portal gas is there. Long length of non-enhancing small bowel. You can see this bowel. Okay. Bowel, non-enhancing small bowel with nematosis. What we'll call air in the intestinal wall. What we'll call is nematosis intestinalis. It is very classical of bowel ischemia. Also, you can see here. You can see this air. So what is called is portal vein gas, large volume portal vein gas. If it is there, the portal venous gas also, it is very classical of bowel ischemia. So bowel ischemia features, so poorly enhancing non-enhancing bowel wall, nematosis intestinalis is the intramural gas. Like all this, like all rest of the signs are there. People are go through, but remember, portal vein gas and the intramural gas, it is very classical of bowel ischemia. So another question is 76-year-old male presented with acute abdominal pain. He is in a shocked state. This is tachycardic, BP is 80/55 unsupported, peripheral shutdown. So we have gone for a CCT abdomen.
Abdominal
Okay. So
aortic
basically,
aneurysm.
very good, very good. So if you are able to answer this, enough. So basically, this is a abdominal aortic aneurysm. This black one is a thrombus. Okay. So you can see here, this is a ill-defined hematoma in the left of the retroperitoneum. So this is basically a retroperitoneal hematoma. This is a aortic aneurysm with a intramural. So you may not get this type of questions also. So, but you just remember these are the common, basically all types of questions related to critical care, not like abdominal, colon. There is some diverticula is there, some GST is there. They will not ask you this type of questions. So they will ask you something related to critical care. Okay. So now another question is a 43-year-old male is brought to emergency road traffic accident, was hemodynamic unstable, but complaining of severe neck pain. Neurologic examination is absolutely normal, no neurodeficit, but a CT cervical spine was performed to rule out anything abnormalities. Okay, can anybody comment here?
Body is fractured. And transfer.
Okay.
C7,
Any other?
C7
Very good.
fracture.
C7 fracture. So basically here you can see there is a burst fracture of the C7 vertebra. So we have to count down. So this is the number of vertebrae you can see also. So the fracture was the vertebral body. You can see the vertebral body and extends to the lamina, body and the lamina. So fracture extends to the right lamina and also the fracture body. So in the cervical spine, if you are able to identify this fracture also, they will ask you, because cervical, any type of trauma, you have gone for the cervical spine, CT scan to rule out the fracture. Because this is very important from critical care point of view. If there is cervical spine fracture, we have to inline stabilization during intubation, all these things pertaining. This is very in our management, it usually helps. That's why we have to go through, identify whether there is cervical spine fracture is there or not. Okay. So now I'll go to the city brain, because city brain is also very important, because everybody will get a city whether we are getting city abdomen or not, but city brain is a must, because in trauma, like stroke, all these things, city brain is easy for you also. You have to identify also, because it's stroke, you have to thrombolize. If it is bleed, you have to GCS assessment, any EVD insertion, call to the neurosurgeon, all these things is there. That's why city brain is a must. Before going to city brain, you should remember how to interpret. So basically, city brain, you have to go through whether if you in the city brain, whether it is symmetry or not. So basically, your sulci gyri appear in the both sides are same or not. So if it is asymmetry, so that's midline shift or like that symmetry. Then we have to go to the gray white differentiation. So basically, whether if the differentiation is lost, then you can tell that sometimes you have to the early sign of CBA on the CT scan, the loss of gray white interface on the CT scan. Also compare this side to that side. If the stroke is the right side or the left side, also we have to comment. So we have to go to the shift of the like midline shift. The puck should be in the midline with ventricle on both sides. So checks for replacement. So basically, your ventricle is compressed or not, whether midline shift is not there. Also have to comment on the any hyperdensity like blood, calcification, contrast. They will appear like lighter, air, fat, and air tremor, they will appear darker. So we have to comment on the ventricle simultaneously, third, fourth, and lateral ventricle for dilatation, like any hydrocephalus or any compression or shift is there. Okay. So now you should remember when viewing a CT scan in the window, low attenuation, that is air, very little radiation is absorbed, allowing most of the radiation to pass through the air through and hit the detector. So the resulting image displays dark. So basically, you should remember in the CT scan, which one will appear black and which one will appear white. So basically, like translucent, which is the blackish. So basically, metal, calcium, blood, and gray matter. So white matter, little bit gray. So CSF, water, fat, and air. So this is the basically accordingly we should like your mind will able to interpret which one, whether it is blood is there, so whether some metal is there, whether like all these things we have to answer. So in the like CT scan, there are 4 window like brain window, bone window, soft tissue window, stroke window. So basically, sometimes they will give you a CT scan, this type of thing. So basically, they want to comment whether there is in the bone window any fracture is there or not. Brain window, so they will typically they will give the brain window. Very rarely they will give a stroke window. So basically, you people should be very much well versed with the brain window. Okay. So with this, actually, we'll go to the cases. So basically, in the cases, we should remember which one is the stroke, which is the ICH, which is the like hydrocephalus, all these things. So here I have given you, so 77-year-old woman, sudden onset of the left side weakness and numbness. He was seen normal 4 hours before reaching to the hospital. So immediately after arriving to the hospital, we have advised for a CT, which is there. Can anybody comment on the CT?
A malignant stroke.
Exactly. So basically, there is a large right MCA territory infarct. So not malignant. If it involving almost 70% of the like hemisphere, you can tell it's malignant. So this is not malignant, but this is a right MCA territory infarct. You can see this ventricle. So that is compressing the ventricle. So that means there is some shift of the midline shift. So your answer will be there is a right MCA territory impact with some amount of the midline shift. So then they will ask you the secondary questions like how will you manage this patient, whether will you intubate this patient or not, whether will you thrombolyze this patient or not. So what is the your window period, all these things they will ask you. Okay. So now the second question is, it is a 24-year RTA patient, present rotopic accident, present with loss of consciousness. Now this is the CT scan.
Extradural numbness.
Excellent. This is easy for you, but this is a mark patching. That's why I've told you this is easy for you mark patching. Just identify what is the difference between subdural and extradural. This is the extradural hematoma, which is a lane sepate, does not cross the suture line. Same thing, this is the 56-year-old male who had a fall 10 days back. So what is this? See? Actually, acute and chronic subdural hemorrhage. So basically subdural, what I've told you, this is crescent sepate one. So why this is 2 colors? So that means one is acute, one is chronic. So this is crescent sepate, does not cause suture line. So this is crescent sepate. This is like concave sepate, so lens sepate. So this is the difference between epidural and subdural hematoma. So extradural hematoma and subdural hematoma, this is the, you should remember, one is like biconcave and doesn't cause suture line. Another is typically crescentic. and more extensive than it is. Okay, so basically this with the shape we have to remember, and whether it is acute or chronic also we have to remember. Also, if it is a EDS, they will ask you what is the management. So if it extradural hematoma, it is a emergency. Subdural hematoma patient can stay for like 24 hours to 72 hours, as long as the patient is, sometimes it is not very large and the patient is not showing any signs of deterioration. Sometimes you can wait if the patient is on anticoagulant, something like that. But extradural hematoma, it is an emergency. If you're not able to operate in the if the patient is showing some signs of deterioration, patient will not give you time. So that also you should remember. This is another question. 54-year hypertensive suddenly got collapsed at home. CT scan shown below. What is your diagnosis?
IVL, sir.
Okay. So basically, what do I tell you? Pardon? So basically, this is a large hemorrhage in the left thalamus extending to the ventricle, that is intraventricular extension. So you have to mention this is ventricular extension, this is most, this is left thalamus bleed, and it is going to the intraventricular extension. So immediately they will ask you what is the line of treatment, what is the anti-edema measurement, how will you control the intracranial like ICP. So whether you will involve the neurosurgeon, what is the indication of the EVD, external ventricular drain. All these questions they will ask you as the secondary question, but you have to answer this question. Okay, this is a 50-year male brought to the ED after out of hospital cardiac arrest. He has a prolonged CPR prior to return to the spontaneous circulation. Following ROSC, despite double vasopressor, he remained hypotensive with a systolic blood pressure hardly touching 80. So we have advice for a CT brain. Can anybody comment on the CT brain?
Loss of gray matter differentiation, subarachnoid hemorrhage.
What is this? What is this?
Crescentic hemorrhage. Sorry, hypoxic ischemic effect.
Okay, so basically you have partly answered. So basically, so you can see here you can see narrow slit of the ventricle, sulci are effaced, global loss of the gray white matter. So basically this is like severe brain edema is there. Okay. Second thing, these you can see here, whatever this. So basically the blood vessels look dense compared to the brain tissue. As your brain tissue is extremely edematous and it is hypodense. So here the brain vessels looks prominent. It looks like SH, but it is not SH. What we call is pseudo subarachnoid hemorrhage. Pseudo subarachnoid is an artifact on the CT imaging seen when the intracranial vessels appear more dense compared to the brain parenchyma. Pardon? So caused by diffuse cerebral edema, which lower the density of the brain tissue on the CT, making the vessels appear more prominent by comparison. Okay. So basically there is
if history is not given,
Yeah.
can we comment? If history is not given, can we comment as SH, sir, this case?
My next question is there. We have to, then we will be very clear. So here, you can see if you are not able to see there is brain edema, brain is extremely edematous, then in that time you will not able to comment on this system. You got my point? Because of the edema, these vessels got prominent. This is not SH. This is called pseudo SH. Okay. My next question is, this is a 45-year female patient with sudden onset headache since last 4 hours. CT brain drawn.
This is it.
Now,
Yes.
okay. Now you are able to differentiate the brain tissue. What I have shown there, now I have shown here. Are you able to comment? Okay. Here this is like SH. This is perimesencephalic SH. So basically here the gray-white differentiation is not lost. It is there. So here if this is the subarachnoid hemorrhage. But what I have shown you here, see here this is totally edematous. In these cases, you are not able to comment on the SH. In the SH, you should remember what are the systems. So basically, you should remember what is the like Sylvian system, what is quadrigeminal system, what is circummesencephalic system. So accordingly, we have to like supraciliar system, quadrigeminal system. So accordingly, the system wise, we have to tell this. This is the SH involved in the supraciliar. This is quadrigeminal SH. This is supraciliar SH. All these things you have to remember. Okay. Now we'll go some in like MRI brain. MRI brains like provide detail of the brain, spinal cord, and vascular anatomy. So what is the advantage of the MRI brain over CT? It's able to detect flowing blood and cryptic vascular malformation, detect demyelinating disease. So no beam hardening artifacts such as seen in the CT. That's why the posterior fossa is more easily visualized in MRI than CT. So imaging also performed without any ionizing radiation. In the MRI, I highlight you just what is T1 image, what is T2 image. Remember and able to identify what is the flavor one, what is T1, what is T2. So this is the difference in the like T1 CSF will be dark, but here it's bright, it will be like dark. In the white matter, it will be light, it is dark gray, it is dark gray. Cortex, it will be gray, it is light gray, light gray. Fat will be bright, and all the inflammation like infection, demyelination, it will be seen dark. Here it will seen bright. So basically, on continuously seeing and practicing, you people will be able to understand what is T1, what is T2, what is flare. So though you may not get a question on MRI, but I have kept some questions here on the MRI. Just typical, if you are getting this type of questions, we will get this type of question only. Apart from that, you will not get it. So basically, it is a 65-year-old male which presented with confusion and cortical blindness. His blood pressure is very high. So it is like, what is your diagnosis?
Press syndrome, sir.
Very good. So this is very classical. That's why I keep giving you the classical clinical scenario. So basically, this is a FLAIR MRI image. This shows hyper-intense lesion in bilateral parieto-occipital area. What we call is PRESS, posterior reversible encephalopathy syndrome. So basically, if you are able to answer this question, they will ask what is the immediate line of management. Control of the blood pressure, supportive care, this patient will get clinically better. So this is a 34-year-old male present with confusion, fever, agitations for last 3 days. He was disoriented with weakness of the left arm. MRI brain is shown. What is your diagnosis?
Temporal in yes.
Classical. So that's why I put this MRI. This is a classical T2 signal showing left temporal and insular cortex enhancement. So basically, I have given a very classical one. So sometimes if you are able to get anywhere like right or left temporal lobe involvement, especially temporal lobe involvement, and the history of fever, confusion, and some disorientation and the clinical examination showing some neck rigidity, so for meningitis, then your diagnosis is very classical of herpes encephalitis. So they may ask you how you conclude to the diagnosis. We'll go for the CSF study.
CSF.
Okay. So this is a 54-year-old male present with headache, confusion, nausea since last 10 days. This is the CT scan. Okay. So as this patient is not getting better and you are able to not getting better, we have gone for a MRI. This is a T1, this is a T2, this is a FLAIR image. So anybody comment what is this?
Yes, some
tumors.
Yeah, this is the mass. So mostly it is a tumor with the surrounding brain edema. See, you can see this. This is surrounding hypotension. This is typical of brain edema. This is the mass. Okay. So this is my last question. This is a 76-year male, hypertensive, taken to the hospital, which is drowsiness since last 5 days. CT brain was turned normal, sodium was low. So he has correction in the emergency department, shifted to ICU. But after 2 days, you have found this patient is quadriplegic and is not able to cough out secretion. And your sodium was sent, it is 145. And we have gone for, as the patient is quadriplegic, we have gone for MRI. What is this MRI finding?
Contain osmotic demyelination
syndrome. So basically, I've given you the clue. So basically, if you are smart enough, you can see this is the pons. In the central pons, there is some hyperintense lesion, which we called is. So in the FLAIR image, showing classic trident shaped pontine signal hyperintensity, what is called previously calling central pontine malnutrition, now it is called osmotic demyelination syndrome. So this is very classical. That's why I put here, but they will ask you what is the treatment, what is the cause, all these things you have to answer. The last question of the MRI, it is 80-year-old female was referred for evaluation of a progressive loss of consciousness. So basically, this is the all the sequence T1, T2, like flare, and this is the diffusion sequence. So all these things I've given. With this, you have to able to answer anything. What is the cause? So basically, yes. So basically, this is a malignant MCA territory impact. So basically, hypotension in the right MCA territory in T1 with increased signal in T2 flare. So in the diffusion weight, it's the brightest signal in the right MCA territory, confirming the cytotoxic edema due to hyperacute impact. So basically, this is a malignant impact. So involving so basically for this patient, CT scan we have done. So initially we are not able to get something in the CT scan. So sometimes in the early phases within the initial 6 hours, 6 to 10 hours, maybe up to 24 hours, the CT cannot pick up this hyperactive impact. For this, if you are in a doubt, if you go for MRI, then it will get the confirmation. Okay, so with this, the radiological part I will finish because it's already 9:30. We'll go to the next part, the laboratory investigation. Before going to the laboratory investigations, I may highlight you may get any type of questions in the lab, starting from all type of study, CSF study, ascitic fluid, pleural fluid, blood investigation, urine routine investigation, also your blood culture, anything they will ask you in the lab investigation. They may give you anything data and they will ask you questions. But for me, it is not possible to go through, but at least 8 to 10 questions I put you for your reference. So I'll go to the questions, then we'll discuss. Okay. So here is a 43-year-old patient admitted with the examination of the CLD. Results of an ascitic tap and serum results are listed below. So comment on the biochemical report and the possible underlying diagnosis. This is your ascitic fluid report. This is the serum report.
SB.
Can any?
Spontaneous bacterial peritonitis.
Why? Can anybody tell me why it is SBP?
White cell count is more than
250 without.
Anything else? Anything else? Anything else?
Albumin saccharide.
So basically, your first diagnosis is spontaneous bacterial peritonitis. Maybe sometimes like malignancy, tuberculosis will be there, but your first question is spontaneous bacterial peritonitis. So any ascites report will get whether it is exudate or transudate. So you have to you should remember one is SAG. You know that what is SAG? Serum ascites albumin. Okay. They will ask you what is SAG, what is the value. If the value is more than 1.1, what is this? What is the is less than 1.1? So basically, if your SAG is more than 1, so that means it's considered high SAG. It is indicating the presence of portal hypertension. Okay. So if it is less than 1, so it considered low SAG, so indicates the absence of portal hypertension. So here mostly it will go to the exudative type. It is mostly transient type. Okay. So basically, if your the criteria is ascitic serum ratios, if the serum protein ratio more than 0.5, ascitic fluid LDH is more than 0.6, ascitic fluid LDH absolute value is more than 0.6. So if is any two of these criteria is there, you can call it exudate. If it is exudate, then you can fit to any type of infection like anything like tuberculosis, malignancy, or SBP also you can fit these ratios. So you have to remember these two things, whether it is a high SAC or low SAC. So they will ask you questions. Accordingly, we can comment on your ascitic reports. So here one more clue was there. So basically your leukocyte count was very high and your pH is acidotic. So this is strongly associated with SBP because here we have given this like clue. Okay. Or also second thing was the LDH was very much elevated. So taking all these things, it is a exudate. Your exudate as the count is very high, more than 250. So your first diagnosis is spontaneous bacterial peritonitis. As you people are telling, absolutely correct. So this is a 44-year-old man. He's present with a headache, dizziness, nausea, generalized malaise for few days. He was highly febrile and neck stiffness is there. Rash on extremities and the wrist is present. So you have gone for a CSF study. Okay. So here WBC count is very high and it is mostly neutrophilic. Your CSF report is there. What is the diagnosis? What is the treatment?
I think pyogenic meningitis.
Why you are telling this pyogenic?
Because the
Very good. Pyogenic.
very low, the proteins are high, the high WBC count.
So low glucose, sorry, this is high protein and high polymer nuclear count. So these three, low glucose, high protein, and high polymer nuclear count, it is favoring in the line of bacterial meningitis. Then your next question will be, what will be the treatment? So what is the vancomycin dose? What is the ceftriaxone dose? When you will add dexamethasone? All these things they will ask you as a supportive question. So you will be able to differentiate between what is bacterial, what is viral, like tubercular, all these things we have to. So another question is a 40-year-old male with HIV infection, documented infection on antiretroviral therapy, present to you with 2 weeks history of severe headache, followed by fever, malaise, vomiting, and confusion. So CT scan of the brain is normal, but a CD4 count is very less, it is 77, and you have advised for a CSF examination to rule out any meningitis. This is your CSF report. What is the most likely diagnosis and what is the appropriate treatment? This is the normal range. This is the patient value. Can anybody comment?
Partially treated bacterial meningitis or viral meningitis?
It's a aseptic meningitis.
Aseptic meningitis. Why it is not tuberculosis? Your protein is very
protein
high.
is not high.
High, but it is if your count is like if it is more than higher than the double, it is 0.4, it is 0.9. Because it is
Lymphocytic.
yeah, this is
Lymphocyte.
mononuclear. Yeah, this is mononuclear. This is like this is
Fungal meningitis.
So basically, this is high protein, low glucose, increased mononuclear cells. So basically, your diagnosis is fitting whether it is a TB or it is a fungal cryptococcus. So as in the clinical context, this although other causes of infection by the mononuclear predominant, basically TB are possible, but as this patient headache on presentation, CD4 count very low, CSF white cell count low, makes cryptococcal meningitis most likely diagnosis. So basically your differential would be like TB versus fungal. Okay. So in the clinical context of HIV infection with CD4 count is very low. So fungal is more predominant than tuberculosis. Okay.
Sir, what about opening pressure?
Opening pressure is high.
So in both it will be high, in TB and fungal.
Yes. In tuberculosis, in fungal meningitis, your opening pressure will be high. You cannot comment. You cannot comment only on the opening pressure. Always just compare with your cell count, protein, clinical context. That's why I've given the clue. So if you'll tell tuberculosis also, it will be possible. So, but we only thing is for the tuberculosis, everything we have to confirm with like your other supportive like PCR test or everything. Okay. So culture, PCR test, all these things we have to confirm. So in the CSF, you have to remember the normal. like what is the pressure, what is the like WBC count, what is the proteins, CSF glucose, all these things. Also, this slide actually I have taken it from like Journal of Critical Care Medicine 2019. This table you just go through. So what is the CSF in bacterial, tuberculosis, viral, fungal, aseptic meningitis? Accordingly, you have to remember where the TB and the bacterial glucose will be low, normal to like in the fungal low to normal. So all these things and what is the WBC count, what is the culture, what is the like pressure, all these things will increase. See, all these things, fungal mild increase, but TB will be increase and bacterial increase, but it will be elevated. On that basis, it is difficult for you to comment on this whether it is fungal or tuberculosis. So this is a very good like table I have taken from like Indian Journal of Critical Care Medicine. But if people go through or any other table where you are able to like comfortable, you can take it and go through. So next question is a 57-year male patient, chronic alcohol abuse patients, present with shortness of breath and abdominal pain for 2 days. Here your chest X-ray right side of pleural effusion. We have gone for the pleural tapping. So this is the pleural fluid report and this is the blood report. So describe the results and what is the diagnosis. Can anybody comment? Okay, good. So basically here you can see your glucose is low, LDH is very high, and the pH is acidotic. So you should remember what are the Light's criteria. So basically pleural fluids, protein and serum protein greater than 0.5, pleural fluid LDH upon serum LDH greater than 0.6, pleural fluid LDH greater than 2/3 of the serum LDH upper limit. So serum level upper limit is 140 to 280. If it is more than it, so it is more favor of the exudate. So your answer is, so basically it is exudative pleural effusion, pH is very low, low glucose, so LDH is very high. So basically in the clinical context, this patient is presenting with the fever and shortness of breath, right pleural effusion. Mostly it is showing you can tell this not empyema, you can tell this basically it is a pneumonia with pneumonic effusion. You can tell this like that because empyema it is difficult to whether after this pleural tapping everything you can tell that. Okay, so I will give you, I think your ABG has been covered, arterial blood gas analysis, but I have put here the question. Here, a 36-year-old male presented to ER by the nearby police lying in the street with empty liquor bottle, the unresponsive, people equal, minimum reacting light, BP, vitals is extremely tachycardic, little bit tachycardic, rest okay, but pH is pH, PCO2, bicar, PO2, and this is the electrolyte, creatinine 1.6, lactate 1.4, ketone negative, salicylate negative. Comment on the ABG and give your probable diagnosis. So I think you people are able to comment on the ABG, but just one thing I'm just going through. When going for the ABG, just history taking and physical examination is a must. Apart from that, validity, we should go to the steps like validity of the ECG, identify the primary disturbances, check pH, then bicarbonate PCO2. Accordingly, you go to the primary disorder, then compensatory response, Anand gap, delta gap or delta ratio, urine Anand gap, formulate the diagnosis. In the ABG classes, it will be covered, but here, like the steps, so we go to the validity of the ABG, then your acidity or alkalosis is pH 7.1, this is acidosis. As pH is the same direction, so it is mostly metabolic acidosis. Then you go for the respiratory compensation. So as the actually PCO2 is 35, so it is coming to almost 28 to 24 to 28. So there is associated respiratory acidosis. So as the primary disturbance is metabolic acidosis, I have gone for Anand gap. So it is a high Anand gap acidosis. So after it will get high Anand gap, then we'll go to the delta ratio, delta Anand gap upon delta bicarbonate. So it is getting more than 1. So if it is more than 1, associated metabolic alkalosis. So why I have kept this? Because you should remember the steps. So they'll ask you the steps. So your final diagnosis is a high anion gap metabolic acidosis plus respiratory acidosis plus metabolic alkalosis. So basically triple acid base disorder. That's why I put these questions, because if people just go through the steps. So another question is the 54-year admitted to ER, the 2-day history of acute severe diarrhea. Potassium is 2.8 and your creatinine is mildly high, 1.4, pH is 7.31, PCO2 32, PO2 98, backup 16, your urine sodium is 60, potassium is 25, chloride is 90. What is the diagnosis? Same thing, we have to go to the validity first, then your ABG acidosis or alkalosis. If as the pH is less than 7.4, it is a metabolic acidosis. pH and PCO2 bicarb in the same direction. Then go for the compensation. As it is within the range, so adequate compensation is there. Then you have to go for a anion gap. It is a normal anion gap metabolic acidosis. So if it normal anion gap acidosis, then we'll go for a urine anion gap. As the urine anion gap is negative, so it is the GI cause of acidosis. So your final diagnosis is it is a non-anion gap metabolic acidosis. So the origin is diarrhea or GI origin. So mostly it is a non-anion gap metabolic acidosis, mostly due to diarrhea. So as your ABG classes has been finished, so I think you just practice what is the steps. That's enough. So respiratory, it will not be a problem. But in metabolic acidosis, everything, just go to the last two steps like urine anion gap in cases of the metabolic, non-anion gap metabolic acidosis. And in the high anion gap, you have to go for the delta gap. So it is another question. It is 26-year-old male. So he's presented to ICU 7 days ago with a traumatic brain injury. Now are the following blood and urine results. Okay, the sodium is 128, potassium, chloride, bicarbonate is 19, glucose within normal range, urea, creatinine is a little bit high, major osmolality is 267. This is the urine value. Urine osmolality is the normal range, urine chloride, urine potassium, urine sodium. So basically give two possible diagnosis and the rationale of your answer. So why I've kept this question? So basically, anybody want to comment on this question?
SIDH.
SIDH.
Cerebral salt.
Okay, excellent. So basically, your two diagnoses, this is one is twisting, one is SIDH. As it is a case of traumatic brain injury and present with hyponatremia. So you two things like SIDH, it may be SIDH, it may be cerebral twisting. But can anybody tell me why it is not SIDH, why it is cerebral short twisting? My answer is cerebral short twisting. Can anybody defend? So basically, my question.
We have to look the volume status of the patient.
Okay. How? So this is the clue they have given.
Urinary sodium
76. So basically, these two in the clinical, what is the clinical feature where we can distinguish between cerebral short twisting and SIDH?
subarachnoid hemorrhage.
No. Clinical.
Volume status, euvolemia or hypovolemia.
Excellent. So if there is in the clinical, they have not given any clue regarding the hypovolemia or hypervolemia. Then what clinical like biochemical parameter will you see to distinguish between hypovolemia? That's why I've written for this patient high creat, low bicarb, low plasma osmolarity, and a high anion gap. These are the signs of hypovolemia. Plus, this patient indicating an ADH response which is appropriate. This is low plasma and high urine osmolality. Okay, and urine sodium is inappropriate high. So basically, these two to differentiate between SIDH and cerebral short twisting, it is very difficult. Both will have same types of clinical features, something, but clinically also it is very difficult to distinguish between hypovolemia and hypovolemia. Apart from we will go to echo, ultrasound, all these things clinically. Otherwise, your extra volume status here will be normal to high, in low in cases of the cerebral salt twisting. So then we have to go through supplemental, like your uric acid level will be very high, little bit high in cerebral twisting. Apart from like urea, pre-renal like symptom like urea will be high, uric acid, creatinine will be high, like bicarb low, pitches of metabolic acidosis, and your like you'll check the like volume status, like IBC will check, echo will check, all these things volume status will be, then you can reach a diagnosis of the cerebral short twisting. That's a put this picture because it is a very favorite questions of the all the examiner distinguish between cerebral short twisting and the SIDH.
Sir, last to last slide, sir. No.
See, in the SIDH, your SIDH response will be inappropriate, but in the cerebral short twisting, the ADH response will be appropriate. So that means it will reserve your like plasma osmolarity and will be low, and your urine osmolarity will be high. So inappropriate ADH response, what we called is SIDH, which will be reserved in cases of the cerebral short twisting. Okay.
Yes.
So this is the last question. This is a 67-year-old male, 8-day initiation of the treatment of the acute leukemia. And this is the clinical feature, all the lab result. So give the yes, it is easy for, as I am giving the clue. Sometimes also in the exam, mostly they will give the clue. Okay, so this is the case of tumor lysis syndrome. Here there is a renal impairment with hyperkalemia, hyperphosphatemia, hyperuricemia, and they will ask what are the like treatment, like adequate hydration, treatment for hyperkalemia, and renal replacement therapy in case of severe metabolic acidosis, hyperkalemia, and allopurinol, aspiric acid. So basically, when you give this type of questions, they may not give you like blood cell is there. They will just give you a like lab parameter, but they will give little bit clue like lymphoma patient on chemotherapy. After starting chemotherapy 24 hours, this is the lab report. From this you will give the clue that mostly this all these things like potassium, phosphate, all these things high. So then you are able to answer. So abnormality tumor lysis syndrome, we should know hyperkalemia, acidosis, hyperuricemia, like hyperphosphatemia, raised alkaline phosphatase, LDH, all these things you should remember. What are the hyper feature you should remember in cases of tumor lysis syndrome. This is another question. This is the 47-year-old gentleman transferred from the regional hospital for repeated seizure. His initial broad results like this. What is the biochemical abnormality? What is your probable diagnosis? Can anybody comment? This is a lab. This is the like hematology report. So the HB 6.7, platelet is low. Your smear is some fragmented cell.
TTP.
Excellent. So basically here I have given the clue. There is renal impairment, there is anemia, there is thrombocytopenia, there is hemolysis. So basically anemia, renal failure, hemolysis, and in the cases of patient is presenting like seizure. So with this your diagnosis is TTP. So if you are able to answer this TTP, then they will ask you what is second line therapy, what is the role of steroid, they will ask you. Okay. I think this is the last question. It is a 57-year-old female. So present with hematological and coagulation profile post admission to the ICU after intra-abdominal sepsis with significant blood loss. This is the parameter. So what is the cause of coagular abnormality? How will you correct the coagulopathy? So basically here is anemia, low platelet, PTINR deranged, and your fibrinogen is also less. So what will be your diagnosis?
DIC.
So basically this is the DIC, Low platelet, increase PTINR, low fibrinogen. So two things can be occur. Maybe because of sepsis, patient has gone to DIC. Also, hemodilution of the inadequate replacement of blood and hallucinal. So how you correct this? Ensure this patient should be normothermic and correct to acidosis. Platelet you have to give, FFP to give to replacement this type of clotting factor like 2, 7, and 10. And cryo you have to give like to replace factor 8, fibrinogen. If FFP does not reverse the INR, and sometimes simultaneously you have to correct with calcium, exclude ongoing or like surgical hemorrhage also you have to correct. I think I finished it. So it's not possible to go through for me to go through the like your urine examination. Also your to go through your like antibiogram everything because it's a time limit. Still, I've taken almost 2 hours. So I think Dr. Tapas will guide you how to go through. I think Dr. Tapas.
Yeah. Yeah, you have covered the, I think, most important as well as mark fetching table. If you know, you can score 100% in this like no station. The other stations you may skip or you may miss some of the important points. But here, if you know it, you will get the full mark. So as Dr. Vishwavikas has told, one thing I would advise you to go through antibiogram. How to like interpret the culture sensitivity report, how to start antibiotic stewardship, antimicrobial stewardship program in your ICU. Have you like ever been part of your antimicrobial stewardship program? So these are some of the questions they may ask you as part of any of the stations. So just remember, and you can go through one or two of the selected articles. I can share also one or two good article like in the group itself. Okay. So without wasting further time, let's thank Dr. Vishwavikas Mohanty for this enlightening and very impressive lecture related to the X-ray, CT, MRI as well as lab. So now coming to the last part of our like the 2 days marathon discussion for your practical test. So here comes Dr. Santanu Bakchi, who is the consultant intensivist from Tata Medical Center, Kolkata, and he will be discussing about again one more important station, that is drugs and equipments. So Dr. Santanu has agreed candidly, despite his family commitments, to be part of the 2 days the marathon academic event. So we must appreciate his efforts, and over to you, Dr. Santanu. Dr. Santanu, you are muted, Dr. Santanu.
Yeah. So thank you, Bhai. And it was such a brainstorming session by Dr. Vishwavikas Mohanty, and I was also listening to it, part of it. So great one. Now this session, as the heading says, like drugs and instruments, it's not going to be a lot of that of a brainstorming one. Rather, I'm going to cover the uncommon drugs, nor I'm going to show the uncommon instruments, because the reason being, in your exam, in your final exam, you will never, I can guarantee that you will never fail for missing out an uncommon drug or uncommon instrument. Rather, you can make a very bad impression if you don't know a common complication of a very regularly used agent, be it a drug, be it an instrument. So, in this table, we would like to cover, or we would like to show or highlight how, from your common drugs or common agents or common instruments, how the questions can be framed. That's all. Nothing else from this session. So, with this, first we'll try to cover the drugs. So, whenever you get any drug, the questions can come in different ways. Like the examiner might ask you about the common side effects directly. The examiner might ask you what is the mechanism principle of action of this drug, or examiner might go towards the different routes of the application of that agent. So how all in different routes it can be used. So the questions can be framed in different ways, but the idea will be to see whether you are a safe intensivist, whether you know the common uses or common complications or common precautions of using the drug when you are using adenosine, whether you will give the adenosine dose in the same dose through a central line and as well as a peripheral line. Whenever you are using adrenaline, what is the dilution in the ampoule and what is the dilution you make when you are pushing it during a cardiac arrest scenario. Or like the recent very important paper which came up, probably many of you are aware of, regarding the norepinephrine. One of our Indian intensivist, Dr. Prasad Nasha, was also part of it. So it has very detailed, it probably got published in January 2024 itself. So it has got very detailed discussion about the commonest, probably the one of the most common drug of an ICU, that is norepinephrine. What is the tartrate solution, what is the how do you prepare, what should be the infusion rate, everything has been discussed in detail in that paper. So those things are the areas which examiner want to see, whether basically whether you are a safe intensivist or not. So coming to one of the very common agent, there is amiodarone. You might be asked about the adverse effects, because amiodarone is notorious for not only its effect, if rather notorious for its different type of adverse effect, be it on the acute situation, be it on the chronic use. So they might go into the mechanism of action. So from there they can go into the different anti-arrhythmic mechanisms. So different classes of anti-arrhythmic agents, how do they act, so those things also can be asked for. So coming to that, the very common side effects of amiodarone, as you all know, it can affect some thyroid hyperthyroidism, it can have some skin discoloration, liver dysfunction, hypersensitivity, those things can be there. In the longer run, it can have some pulmotoxicity also, as well as it can always cause a QTC prolongation, it can cause sinus bradycardia, those things need to be taken care of. From there they can go into the typical mechanism of an antiarrhythmic agent, and before that they can ask you about the classification of the antiarrhythmic agents. So at least the older classification, that is 1A, 1B, 1C, class 2, 3 and 4 type of antiarrhythmic agents you need to mention. They can ask you where those agents act, like class 2 agents, which are the class 2 agents, so you need to mention it's the beta blockers, what they do. They act on the potassium channel rectifier channels. And then similarly, the potassium channel blockers, the class 3 agents, where do they act? Be it in the class 1 agents, like the sodium channel, classical sodium channel blockers. So what are the different agents, whether it's a weak blocker, whether it's a strong blocker, which agent is the which group of antiarrhythmic agent is a strong sodium channel blocker. So those things they can ask, and they can ask you the names also, name one or two class 2 agent antiarrhythmic agent, or class 4 antiarrhythmic agent, or amidon belongs to which class of antiarrhythmic agents. From there they can go into, you must be aware of the recent antiarrhythmic agent classification, where instead of going up to the class 4 agent, the classification has been stretched beyond 4 and it has gone to 7. So that can also be asked if you are answering rightly. Then from there, the different cardiac action potential effect of different antiarrhythmic agents they can ask for. Most commonly the QTC prolongation, they are very fond of asking which are the agents who are strongly increasing the QTC. So you need to mention the class 3s as well as class 1A. They are very much notorious for increasing the QTC grossly. Similarly, they can go for peer, they can ask you, like, if the peer is already prolonged, so which agent you'd like to avoid. So you need to again mention the class 3 agents needs to be very cautious to be used with. So from there they can go into that. Next we can think of some antibiotics. Definitely, see, in a drug table there will be multiple drugs. Many of the examiners are fond of asking, like, pick up a agent. So whenever you are like, I was also asked in my own exam also, like, pick up an agent. Dr. Atul Kulkarni was my examiner from Tata Memorial. So whenever you are picking up an agent, be very cautious that please pick up only that agent which you are aware, right from the manufacturing to principles of action to dosage to contraindications to indications, everything. So if you are being asked to pick up one agent, pick up only that agent which you are absolutely sure of. So that is there. And otherwise many examiners keep on giving different drugs. So they are usually what they cover. They would like to cover one vasopressor or inotropic agent, one antibiotic, one antiarrhythmic, one sedative or hypnotic or muscle relaxant. Those are the different combinations they keep on rotating. So one of the common antibiotic is meropenem. So if you are giving a meropenem vial, you might be asked about the mechanism, which group of antibiotic it is, then which, if particularly for meropenem, it is very important to remember which group of bacteria are not covered by meropenem. That is one. And similarly, once you can answer that, you will be asked about the different type of carbapenems, like the resistant mechanisms beyond towards meropenem or similar agents. So there you need to mention the classification of the carbapenems enzymes. And then because this is a very important topic, as you will know, so it's very likely that examiner will go towards the classifications and the mechanism of action of different carbapenems. From there, sometimes if the tables are clubbed, you never know about your center. So if the tables are clubbed from this drug itself, the examiner can go into an antibiogram and ask you about typical culture sensitivity, and then ask you which agent you find suitable from this MIC and values and all. So the switching of the questions are very much possible depending on the mood of the examiner. You need to also be prepared for that. Similarly, from an adrenaline drug, they can go into ACLS algorithm. Same thing can happen. They can ask you in non-ACLS situation where what will be the dosage of adrenaline. So those things always will be there. Those switching is always very much common in any exam scenarios. Next come another common vasopressor agent is vasopressin. So one very common question will be the mechanism of action of different vasopressin receptors, like how do vasopressin act. So at least for V1 and V2 receptor, you should mention where the V1 is the vessel specific, V2 receptors is mostly kidney specific. So that thing you need to mention. And similarly, you should mention in the vessels where do they act and what do they do. Usually they causes a profound vasoconstriction, as well as it increases the GFR. Similarly, in the renal part, in the through the V2 receptors, usually what do they do? They act on the aquaporin channels in the collecting duct. So ultimately it causes some retention of the water and subsequent reduction in serum osmolality. So additionally, you can go towards the V3 receptors and then oxytocin receptors and others. So but at least V1 and V2 receptor you should always be able to mention how do they act, where the locations, and one is vascular, one is renal. At least this much should be there very clear from your side. Then they can ask from vasopressin drug only, they can ask about the uses and adverse effects of different vasopressin analogs. So first they will ask, have you heard of vasopressin analogs? Then you will mention yes, like I have heard about vasopressin, terlipressin, desmopressin. So they can ask what will happen when you give when you start terlipressin, where do you use terlipressin, what is the dose of terlipressin, and what precaution you should remember whenever you are starting terlipressin for an indicated patient. Similarly, again, if you are answering well, they can go into the brain dead organ donation patient, those scenarios. So they can ask about the organ protection role of vasopressin, what dose it needs to be given after donation and brainstem death scenario. So that they can ask. Then they can ask about whether desmopressin can cause hyponatremia, what precaution you should take when to prevent hyponatremia, which scenario it happens more commonly, that they can ask about. So these are the different scenarios from which the questions can go. Then another common agent is a voriconazole. So for voriconazole antifungal agent, first thing that the question that will come to any examiner's mind, very commonly it happens, that the mechanism of action of different antifungal agents. So they can ask the common agents like your echinocandins, the azoles, and your amphotericins, nystatins basically. So these three groups, the most common three groups, where do they act, which areas they focus. You need to mention the echinocandins usually inhibit the glucan beta 1,3 glucan synthesis, they inhibit. Similarly, the azoles usually inhibit the CYP 450 enzymes. So once you are done with the mechanism, another two very common areas for voriconazole is One is drug-drug interaction, that always from our day-to-day practice only we need to be very careful of. And second thing is about the adverse effect of voriconazole. So they can ask usually with voriconazole which enzymes inducers are most commonly affected. Then you can mention it is usually the CYP3A4 enzyme. Then they can ask about some common drugs like your proton pump inhibitors. If the patient is on a higher dose of proton pump inhibitors, you need to reduce it. The dose should, if it is more than 40 milligram per day, then the dose needs to be reduced by at least 50%. Then most of the drugs, their action gets potentiated, be it the common anti-cancer agents or warfarin, those gets potentiated with the use of simultaneous use of voriconazole. So you need to be aware of the side effects, possible side effects from those agents. It can be increased nephrotoxicity or it can be increased bleeding tendency. So those things needs to be taken care of whenever your voriconazole is being used. Similarly, from the adverse effect point of view, they are fond of asking the detailed adverse effects. And remember, the increase in transaminase is not extremely common with voriconazole, so we always fear of that. But there are other adverse effects also, from your vision point of view, from your confusion point of view. So those things, QTc prolongation is also very common. So all the adverse effects, ideally you should mention system wise, like CNS I'll have this possibility, CVS this is the possibility, like liver and biliary system this can happen. So that's how, if you approach the adverse effects, that will be a sure shot pointer for you. And see, drugs and instrument table, ACLS table, then your this investigation tables, these are the like scoring ones. So ideally you should not miss even one. So, and always remember, try to answer the simple and basic questions. And rather I would like to say, try not to miss the common ones. So if you answer those things rightly, usually you get a full marks. Toward the end they might ask you some uncommon ones, but that won't cause a problem from your scoring point of view. Then propofol, again a very common agent for an ICU. So remember, for propofol, don't jump into the propofol infusion syndrome, because the examiners are aware that whenever they are giving propofol to an examinee, or you are picking up a propofol, so you may try to bend towards the propofol infusion syndrome, and they might not even ask that question at all. So rather they would like to hear about the common sedation doses of propofol, which receptor it acts on, then what are the common side effects. So whenever you are being asked about the side effects of propofol infusion, propofol as a drug, so try to use the practical side effects. Like they want to see whether you have worked with propofol, whether you have used propofol. So you need to say that it has a high tendency to cause respiratory depression. Then it can mark like blunt the baroreflex response. So even if there is hypotension, the tachycardia may not be there. So those things they want to hear. It will reduce the cerebral metabolic rate. So that is one of the advantage. So these things they want to hear. So you mentioned that there will be pain because of the propofol preparation. There can be pain on injection through a smaller vein. Hypotension is a common possibility. Patient can go into transient apnea. So those things they want to hear. And the propofol infusion syndrome comes as a last option. So don't jump to propofol infusion syndrome straight away, because then the next question will be, have you seen propofol infusion syndrome? So very few of us have seen, probably. And once you are done with all those, yes, examiner can go into the propofol infusion syndrome in detail. And once they are asking about propofol infusion syndrome, they will ask the most two common questions will be, one is what is the rate and what is the dose, like what duration. It should be at least for more than 48 hours. And what is the dose. Any dose patient being on a propofol infusion will develop infusion syndrome? No. There will be a particular dose. It should be higher than 5 mg per kg per hour. Like those doses should be there for more than 48 hours. Then they can ask what are the possible confounding predisposing or precipitating factors for developing propofol infusion syndrome. Then you can mention that at least concomitant, the most common one being the concomitant steroid steroid or vasopressor use. So that you mentioned, because that is very common in any critically ill patient using steroid infusion or vasopressor infusion. So that is one of the precipitating factor, I would say, predisposing factor for developing propofol infusion syndrome. So those things they can ask about. What problem do you face in propofol infusion syndrome? You need to mention this: rhabdomyolysis, significant metabolic acidosis, those things develop. So it can go into that way. Then they can go into, from propofol they can go into the ICU sedation practice. They can go into the FDA recommended agent, the dexmedetomidine. What is the dose of dexmedetomidine? What is the infusion rate? Whether you can use bolus? What is the adverse effect of dexmedetomidine? Whether you are using dexmed or not? What precaution you should take care when you are using dexmed? Those things they can ask about. Then they can go into different sedation combinations: propofol plus fentanyl, dexmidas plus fentanyl. What is the advantage? Where do you use? Where do you don't use? You can even answer from your practical point of view, like in a post-op ICU. If you are working, if the patient has undergone a surgery today and the electively patient is being planned for extubation tomorrow, so in that situation, ideally in that post-op patient, you should focus on a propofol fentanyl combination rather than using a midas fentanyl combination, because naturally midas will have a longer half-life, and our next day early morning extubation may not be possible with midas infusion. So you can answer from that point of view also. Then haloperidol I kept because this is sometimes quite commonly used in many of the ICUs. So from haloperidol, if you are being given that agent, they can ask about the classification of the antipsychotics, whether it's a typical or atypical antipsychotics. Where do they act? In the typical antipsychotics usually are the dopamine antagonist, and the atypical ones are dopamine plus serotonin, either completely or partially antagonist. So that you can mention. Then they can ask about the examples of typical and atypical antipsychotics. So you can name one or two, which one you are using more commonly. Try to name those agents only. Like in our setup, aripiprazole is quite common in the atypical group, so that you can mention. Some setups, quetiapine is common. Then this is a recent nice recommendation only, nice guideline only. So for IV haloperidol dosage, so what precaution you should remember: never miss to mention that ECG role. Like if the dose is really less, like less than 5 mg per day, and very few risk factors like female gender or age, higher age are not there, then definitely you may skip ECG. But most of the times, before and after using starting haloperidol, you are supposed to check for QTC values, corrected QTC value, how much, whether it is less than 500 or not. Those things always has to be mentioned whenever you're using your haloperidol as an intravenous agent. Similarly, correction of the electrolytes like magnesium and potassium is also very important. So that thing also needs to be mentioned. So they can ask about the precautions you should remember whenever you're using intravenous haloperidol. So that way the questions can go. Rocuronium I kept as one of the commonest agent for muscle relax as a muscle relaxant. Although muscle relaxant are not very frequently used, neither we are fond of using muscle relaxant infusion. But for intubation procedure, we do use, and succinylcholine, it's not being used, recommended in an ICU setup. So rocuronium being the commonest agent, probably the commonest agent for intubation in an ICU setup. So they can, from giving the vial, they can go into the typical classification, like what are the different types of non-depolarizing, which class of muscle relaxant it is. First question will be that. So you mentioned it's a non-depolarizing muscle relaxant, so they will ask about the classification of the non-depolarizing muscle relaxant. There you can mention it as a long acting, what are the long acting, which are the intermediate acting, which are the short acting ones. And then they can ask about the mechanism of action. So basically it's a competitive antagonism that you mentioned. Then they can go into detail of the pharmacokinetics. So from there, the one of the very common question will be, what is the rapid sequence intubation dose, like of rocuronium, and what will be the duration in that case of the effect of that agent. So you mentioned that it should be 1 to 1.2 milligram per kg bolus for a RSI dose, and the duration also goes up from 1 to 1.5 hours it becomes. Then again, atracurium and cis-atracurium. From atracurium, what is the seizure potential, which agent causes that? So that can be asked about. Then on the other end, what is the typical metabolism pathway for atracurium, whether like the Hoffman degradation method, that they can ask about. So those things they want to hear. uh, fentanyl is one analgesic. They will be asking either morphine or fentanyl, because remifentanil very rarely being used till now in the examination. Usually morphine or fentanyl is being given most commonly. So whenever you are getting an analgesic, like opioid analgesic, so they will definitely invariably they will go into the different opioid receptors, and they will ask about different agents which acts through the opioid receptors. And as you all know, most of the agents never act or work straightforward, like one agent working on one receptor, usually that doesn't happen. So you can give the classic example of pentazocine, which has in particular one receptor as agonist effect, one receptor they will be having some partial agonist effect, and one receptor like in the mu receptor they will be having some antagonism effect. So you can mention that opioids, these are the four receptors: mu, kappa, lambda, and delta. And these are the common agents through which, like mu, morphine, fentanyl, they work on the mu receptor. Kappa, again morphine can work, and albophenol, those are there. Then lambda, delta, different agents are there, but most of the agents usually work in combination, and they have different effects through different receptors. So that you can mention, but at least these four receptors and one agents for agonism they can ask about. And these are the different doses of fentanyl. Again, through, fentanyl can be given through different routes. So at least they can go into the post-operative pain control, what infusion rate you will consider, where you will consider a lower dose. Sometimes they can ask, from the examination point of view, they can ask about the post-patient controlled analgesia dosage of fentanyl. That can be asked, as many of us might be managing the post-operative ICU, so they can ask about the patient controlled analgesia dosage. These are the different morphine derivatives. No point going into the theoretical part. Daptomycin, again, I kept as one of the uncommon antibiotics, but they can ask about it. They can ask about the mechanism, like where which group of organism usually it covers, and where you should not consider daptomycin, even if a similar group of organism is present, like in lung surfactant, it destroys its action. You should not use it on lung MRSA infection. Then what is the common adverse effect, like which, like it can cause rhabdomyolysis, myalgias, and you should be switching off the statins if it is going on for on the patient. So those things they can ask about. Then they can ask and then again, any antibiotic, if you are being given towards or diverge, or you can be switched towards a antibiogram assessment from that antibiotic. So they can give you a next, after the drug is being discussed, they can give you the antibiogram, and they can ask you to interpret the result, and they can ask you about the opinion of the ideal agent from that antibiogram. That is a very common way of examination that happens in the, like in our exams. This is adenosine. Again, not much changes, like mechanism of action, precaution, which route it should be given, what is the dose, how does the dose changes, what is the common adverse effect, what immediate complication can happen, what you will do, how do you administer adenosine, like whenever you are giving through a peripheral vein, it should be it's a bigger vein, like cephalic vein or like that. And after giving the drug, like the typical 6 mg through a peripheral route, it should be 6 mg followed by 12 mg. So after giving the drug, there should be a 20 ml fluid bolus follow, and hand elevation. Those things needs to be mentioned. Through central venous cannulation, the doses reduces. That also needs to be mentioned. What are the common immediate adverse effects they can ask about? Most commonly the heart block, they will develop sudden bradycardia. So that needs to be taken care of, that can be asked. Next comes the instruments. Like for any instrument, the approach can be like, first they will ask, what is this instrument, do you identify? You will say yes, this is a laryngoscope. Then they will ask about what are the parts of this laryngoscope, for example I'm saying. Then they will ask about what is the use of this instrument, where do you use laryngoscope. what precaution you remember, which way, then you mention that these are the complications that can happen from this instrument using, so these precautions I'll keep in mind. Then they can ask about some special points related to the instrument. May not be all the instruments will have some special point, but some instruments do have, so they can ask about that also. Usually, unlike the drugs, the instruments are asked in a very systematic manner. First they will ask about the identification, then they will ask about the parts, they will ask about the use, precautions, and some special points related to that instrument. That's how usually instruments are being asked. This one common instrument nowadays with an ECMO and extracorporeal support, this is your main probably. I'm not keeping this class as interactive, so there is no, I'm not asking the queries, because this session is quite straightforward. You all know this is a membrane oxygenator. So from a membrane oxygenator they can go into different types of ECMOs, like extracorporeal supports. How do they act, what are the different types, then on this membrane oxygenator, very specifically they can ask about how do the gas exchange happen, what are the factors responsible for effectively causing gas exchange through this membrane oxygenator. Then you can mention it's the permeability, it is about the membrane surface area, the pressure gradient for the gases to get exchanged, an amount of time the gas is being able to be in touch with the blood interface. So those things can be asked. Then they can ask, see, in case of any accidental rupture, which is the more risky part, like for any membrane oxygenator there will be one blood side, one gaseous side. So if the rupture happens on the gaseous side, sudden embolism is a higher risk, so that will cause immediate cessation of the extracorporeal service. So that is more riskier compared to the rupture from the bloody side, so that they can ask. This is your this thing, arterial line or transducer system basically. So they can ask about, whenever you are being shown the transducer system, they can ask about the what is the classical tube quality, what is the classical tube length, then what is the mechanism of transducer system, how do they act through that Wheatstone bridge principle. They can ask in details about the Wheatstone bridge principle. They will not ask you to draw the bridge, but they can ask about the basic mechanism through which it acts. Then what are the common source of error, like your dampening, under damping, over damping, how do they develop, how do you identify that. Then they can go into the rapid flush test or square wave test. How do you do that, what is the normal one, how many oscillation happens in a normal rapid flush test, or how many oscillation develops in a hyper resonant or under damped or over damped scenario. Those things they can ask. This is your macro-laryngoscope. So what is the advantage, what is the specialty in this laryngoscope, which scenario do you use? Once you say it can be used in a difficult airway scenario, then they can ask about the difficult airway algorithm. They can go into that. They can ask about why ICU intubation is different from a general OT intubation. So you need to mention those points where it differs, what are the additional risk factor for an intubation being done in an intensive care setup. Then this is your Venturi mask. So once you get a Venturi mask, first question will be your Venturi principle through which it acts. They can ask about the Venturi principle. They can ask you to draw. They might not ask you to draw a Wheatstone bridge, but they are invariably going to ask you to draw the Venturi principle and draw and show you, like show the examiner how do the Venturi principle act. So they can ask about that. Then they are very fond of going towards the color coding, like which color, how much FiO2 percentage of FiO2 is being delivered, and what is the recommended starting flow rate, that they will ask depending on the color coding. They can ask, just like your anesthesia practice, they can ask in critical care also on this color coding, flow rate, and percentage of oxygen being given. Then they will ask which scenario you will prefer to use Venturi principle, Venturi mask, which scenario you would prefer, what is the advantage, what are the limitations, you cannot increase, or whether you can increase the fixed flow. So those things you need to mention. And this is your IBP, again a bigger domain. Like from IBP they can go into many areas, but most commonly remember any IBP, whenever you are reading, along with the complications and basic principle, you should always remember those four graphs of early inflation, late inflation, early deflation, and late deflation. So how either they will ask you or they will provide a graph and they can show you, please identify what abnormality is happening. And one more thing in IBP they will ask about is the ratio. From any graph they will ask what is the augmentation ratio, whether it's 1:1, 2:1, that they will ask about. And similarly they will ask about the abnormality, whether any early or late inflation or deflation is happening. Once you can identify it rightly, they will ask about the complication, like whether if it is early inflation, what will happen to the afterload. If it is a late deflation or late inflation, what will happen to the hemodynamics, whether it is accessible. Then one more thing, they will ask about the anticoagulation, what anticoagulant you will use, how do you put, which scenario you use, what is the recommendation. Then from IBP they can go into the evidence, like can you name one or two paper which is given in favor of IBP, or whether it has given some in against IBP. So they can go into those evidences also. So many areas it will go, but at least those four graphs, early inflation, late inflation, early deflation, late deflation, has to be very copybook in your mind, because those graphs will invariably come either during the graphs or during the instrument. Those graphs will be there, so never miss those four graphs. It is being probably discussed in detail in all of your classes or many of your classes. This is IVC filter. From IVC filter, the most common question will be the recent venous thromboembolism guideline. What is the recommendation? Which agents being preferred? Which is being obsolete? They can ask about that. They can. One important question is when to remove IVC filter. As because I'm coming towards the end of my session, can anyone tell me what is the current FDA recommendation to keep IVC filter inside the body? Can anyone tell me? I believe some people are still there, though I
3 to
cannot see
6
anyone.
months.
Yeah, yeah, that's why I asked. Actually, this is the common answer. Like up to 6 months we can keep, and even in later also we can continue, because if the patient cannot be started on blood thinners, you may be need to keep the IVC filter beyond 6 months also. There's a common answer, but my question was what is the FDA recommendation. So remember, FDA recommendation, current FDA recommendation is 25 days to 54 days needs to be kept. One IVC filter can be kept, but very commonly if you, even if you say it's 3 to 6 months, examiner will not give you a negative mark, but FDA recommendation is 25 days to 54 days.
If the recommendation
Then
for
what is the
retrievable, sir, for retrievable
part?
filters, FDA
Yeah,
recommendation is for retrievable.
yes. Then what are the complications with the retrievable IVC filter? Like what are the complications can happen with those IVC filters? That also can be asked. Though it is a very uncommon instrument, usually it will not be given. Still, I just kept just like that to discuss about the VT guide recommendations and all. Then lastly, this is your CRT machine. So once you are being shown those machine, you will not be asked to connect the cannulas and all, but they will be very much interested to go into the different modalities of renal replacement therapy. What is the advantage of one modality over the other? And once you answer that, remember, just like your IBP graphs, those four graphs of IBP, this four or six, probably six diagrams of your CRRT, that CAV, CVV, HDF, CVV, VH, those diagrams are again very important. So please do practice those diagrams. This is, I'm not only telling about the DNB exam, but also from your AD part 2 exam also. These are the common diagrams are usually there in your exam. Probably very commonly or very possibly you are going to get one of those diagrams, be it on the IBP side or on the CRT side. These 6 to 10 diagrams, 4 on the IBP and 6 on the CRT. They can ask about where you will put the pre-dilution. They can ask you to identify which is the pre-dilution point, what is the post-dilution point. uh, from this diagram, can you identify what is the technique of CRT being given? So those things, those diagrams, it's better to practice. Little bit confusing to start with, but once you do practice regularly, it becomes easier, because these are the common hot areas currently. IVP graphs and the CRT diagrams very commonly being asked. This is your ultrasonic nebulizer. Again, I kept ultrasonic nebulizer. Once you are being given, then they can ask about what are the different type of nebulization therapies, which agents you can give, what is the role of inhaled antibiotics. You can mention the recent paper of amicus in prevention of VAP, though it's pretty controversial. What is the IDSA guideline for using inhaled antibiotics? They can ask about which other agents you can give through nebulizers, what precautions you should remember in the COVID scenario. How do you provide nebulization therapy for a patient? Those things they can ask about. I guess that's all. And what are the different advantage and disadvantage of different type of nebulizers? They can have mentioned ultrasonic nebulizer, mesh nebulizers. What are the advantage and disadvantage? They can go into those classification and discussion. They will like to hear the common practical points only, not the detailed descriptions. Yes, this is the last one. You know, the HFNC. So the from HFNC they will ask first. They will ask about the advantage, principal advantage, disadvantage of HFNC. Then they will go into the papers, like not only the fluoride trial, any other trials that has come into in favor or not in favor. Where do you prefer? Where do you don't prefer? Where you should avoid? Whether you can incorporate in a difficult airway scenario, whether you can incorporate in the pre-oxygenation in ICU setup, you should always incorporate HFNC or not. Those areas they can go into. So that's how usually the exam progresses. And with this, I would like to conclude our session for drugs and instruments. The idea was to show how things can move from one direction to the other direction from the common agents. Try to focus on your common agents for your exam. That will be definitely my final sentence. Thank you. If you have any queries or any discussions, I don't know whether Tapas Bhai is there or not. We can discuss here itself. It may not be related to drugs or instrument. You can ask any other queries you have related to your practical exam.
What about the logbook, sir? Do they ask questions from logbook or are there?
Very rarely. Usually they go through it. They see as per the national board format whether you have prepared or not. In case they develop a doubt, like you are copying pasting something you have not done, or you have mentioned some atypical one, sometimes it comes to their notice that very rare something you have mentioned. Then they can, you mention amniotic fluid embolism as one of your case you managed in your logbook. So then they can ask, how did you do, how did you identify? Usually not.
What questions do they ask from the thesis per se?
Methodology. First thing they will ask about the methodology, because it is a common assumption. Like imagine I'm an examiner, I'm an old examiner. Imagine the first assumption I will have that you have not done your thesis. That is a common assumption. You have taken some senior's thesis, you have copied it, pasted, put some values, did some statistical things and presented it. So first thing they will ask, if they really want to grill you about thesis, they will grill you about the methodology. How did you do? How did you choose your sample size? How did you do your blinding? How did you do your randomization? And they will ask in detail, like randomization, who had seen? Achha, he has not seen. This person has seen, so this is not valid. They will try to find fault in your methodology. That is the first thing, because statistics, they know your hospital statistician has helped you. You don't know anything about statistics. That they know. They will not bother about that. But even if you know statistics, still I'm saying, but their main area point is methodology. So be very clear about your methodology of your thesis. And once you can satisfy, yes, one more thing can also happen, like once you can satisfy them with your genuine answers, then they can go into your topic itself and they can ask about the papers, like any important paper have you read about this topic, or has been done previously, any international study, important study. If your topic is related something to related to that, you can mention that. Like if your thesis topic is related to HFNC, you can mention about the fluoride trial or any other trial, similar things. So but first thing is methodology. Be very thorough on the methodology of your thesis topic. There should not be any miss on that. Anything else anyone want to ask or discuss? Anyway, groups will be there in future also, you can discuss. Still, as because someone from the team is here, so you can discuss. I'll try to give answer as per my knowledge. One additional thing I would like to say, as because no questions have come up, in your practical exam, the first thing, see, we also were the students few years back, so the first thing that comes before the day of practical exam, that you are such a big syllabus, from where the question will come, which case I will face, and how I'll be able to answer. That is the first thing comes before a practical exam. Remember, the examiner also know that, they knows it very well, that you cannot cover everything together in a detailed manner. You are supposed to forget things. That is very acceptable. Don't miss the basic safety ones. Just like any other exam, they want to see how safe you are, so don't miss the basics. That is the first thing for any exam. If you can stick to your basics well, basic practical management I'm telling about, and yes, principles of management also, so you are pass. Next level is about, then comes like depending on your detailed knowledge and all, you can go towards the gold medal or whatever special recognition. But you are pass if you are a safe intensivist. That is for sure. No confusion in that principle. Today also, previously also it was there, now also it will be there, in future also it will be there. That is the first thing assessed in any practical exam in India.
Sir, one uncommon thing to ask, the exam will be held bedside, and do we have to carry our own scrubs to wear there, or we
No,
or in the
apron.
form?
No. I don't think. I have never seen. Scrubs you don't not to carry, but some of those things which we don't carry on our day-to-day practice, like your apron, like your stethoscope, like your hammer, like one torch, like one measuring tape, those things you should carry, rather you must carry on the day of your practical exam. Apron may not be used, like many of the ICUs don't allow apron inside, but hammer, torch, measuring tape, stethoscope, minimum these four things has to be taken with you. You don't know what case you will get. Anything else, please feel free to ask any question. I may not be able to answer, then we'll discuss it subsequently, or if I know, I'll discuss right now. So if you have any, freely you can ask. Actually, I lost my father recently, so there was some changes in the schedule, but as because I have finally joined, I'll try to share whatever I know right now itself. If you can ask, there will be lots of question about practical. It's
Good evening,
always
sir.
pretty difficult. Good evening, Ritesh.
Sir,
Tell
Dr.
me.
Tushar here. Sir, sorry for
It's
your
showing
loss.
Ritesh. Okay. No worries. Tell me.
Sir, sometimes the examiners ask that you have only one bed left in your ICU, and in emergency you have a
Yes.
very young patient of an
Yes.
18-year-old male having GCS of 3, and an 80-year-old patient with having an pneumonia. So, whom will you choose? So, sir, how should we approach in such case, sir?
Very clear. No confusion. Depending on the survival. what is the possibility of survival. So in that, if those two are the patients in your emergency, sorry, and you are being asked like 80-year-old male and a young guy with GCS 3, even if the GCS is 3, as because the patient is young, the survival chances, the longevity is higher for a younger patient. So you are supposed to choose the younger one, until and unless it is diagnosed as brain dead, then it's a different thing, but it's unlikely to be diagnosed in the emergency itself as brain dead. So the higher survival chances or higher longevity patients should be given a preference.
Sir,
And this
can
will
we
be asked.
ask like that whoever admitted first, we should take first
No,
in
no, no,
ICU?
no, 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 absolutely not. See, you are not supposed to discuss like one patient has come 3 days back, still stuck in the emergency, and this guy has come 2 minutes back. There is a confusing thing, but usually your focus, like I was only asked this question. So this kind of like strategizing, shifting, transfer, like which patient you should transfer to the ICU early, this is a very common scenario. There, the survival benefit, longevity benefit from the patient point of view, from the society point of view, should be given the preference always. It becomes difficult when you are get a similar age patient with a similar disease, so that becomes difficult. Like two, I can give you one more scenario. Two army people has come. We had similar patients in our one of our previous situation. Like two army men has come, both has been diagnosed with malaria, and both has been shifted from periphery to your emergency. So one bed is there, which patient will be transferred, then you look for the severity, like which patient is needing more organ support. The patient who is needing more organ support needs to be transferred to the ICU early. But it is pretty straightforward if it is a between a 25-year-old male and a 85-year-old male, that becomes more straightforward. Definitely the 25 one will get a preference.
Thank you, sir. Thank you very much.
Wait. Anything else, like any other queries or concern about your exam day?
Sir, good evening, sir. Sir, I am Dr. Gauri Shankar. Can you please help me
Hi.
how to take history taking very crisp and fast and without missing anything?
History taking should not be fast. First thing, history taking needs to be detailed. Like most of the, especially North Indian as well as South Indian examiners, they are very fond of asking in detail about your present examination, like history of present illness. What is the, how do you describe the history of present illness? That they are very fond of. There are some areas which they are fond of asking. One is history of present illness. Like there are three symptoms: one is pain, one is fever, one is vomiting. So what is the type of pain? You need to describe in detail. Then what is the type of fever? You need to describe in detail. That is your medicine examination, MBBS medicine examination. Same thing you need to copy, like this kind of intermittent, that what, I also don't remember exactly all those points now. But what is the location of the pain, how, where it is radiating, which, how, what is the elevating factor, what is the aggravating factor, those things you need to mention. Then vomiting, then what is the type of vomiters, what is the direction, projectile or not, what is the smell, what is the color. So one is history of present illness, and again you are mentioning it as per the occurrence, like this is 3 days back, then next part is 2 days back it started, and the third thing started today. So those things should be, that chronological order needs to be maintained. Description, detailed description with all the points and chronological order. That is one, about history of present illness. Then again in the history, very common important history is about medication history. So you need to mention all the detailed medication whatever is going on, because they can ask you in future whenever in that patient. Imagine you have very nicely answered about the history and physical examination, and they have gone into the management part. Then in some scenario you are telling about for example, voriconazole being added, and similarly some already QTC prolonging drug is going on as a common agent, like patient is already on amiodarone or something, so they can ask you, cross you. So will you be cautious about that? So medication history, again, a very important thing, personal and medication history. Then in the examination, at least one system detailed examination they would expect you to do, be it CNS, be it respiratory. That has to be a copybook one, like in detail, or inspection, auscultation, percussion, everything you need to mention what are the findings you are getting. Even if you're not finding, then also mention that ACE1, ACE2 is like this audible, I could not find this adventitious sound. So most of the examiners are very fond of, especially the senior ones, are very fond of history and physical examination. So you should not go in hurry about that. But if you are running short of time, imagine there is a scenario, unlikely or somehow, that you are running short of time, you need to have the history and physical examination very rapidly. So then you should focus on the positive and negative points. Like, see, if you are running short of time in a patient, then at the end, at the time of, uh, you will come to any diagnosis and differential diagnosis on the basis of presence and absence of some of the important points. So try to find out those positive and negative histories. If you are running short of time, try to focus on the positive and negative histories. That's all. That will help you in conclusion, making the conclusion. So there the examiner would like to hear the summary from you. Whenever you are summarizing a case, you need to mention the positive and negative histories after the initial line, like 40-year-old male coming with this complaint, these things are present, these things are not present. So my provisional diagnosis is this, and my differential diagnosis is 1 2 3 4. That's how you should mention.
Thank you so much, sir. Thank you.
Thank you, dear.
Sir, for brain dead patients, should we check all reflexes at the bedside, all reflexes, vestibular?
You will not get that opportunity. They will ask you in practical scenario. For if you are getting a brain dead patient or they go into organ donation thing, two things they will definitely ask. Even if you cannot do all the test by yourself, most commonly you will not be doing all the test by yourself, but they will surely ask about two things. One is the tests for brain dead that you need to remember and tell, that is one. Second, they rather three things. Second is what are the brainstem reflexes, not to show, rather to tell what are the brainstem reflexes you need to see. That is the second thing. And the third thing they will be fond of asking is the different hormone therapies, like different drug therapies, hormone therapies, as well as your vasopressin, all those. Whenever you are preserving, like organ donation, you are doing taking care of a patient for organ donation, what are the management principles you need to follow? These are the three things they will definitely ask. One is surely the test for brain dead. Second is brainstem reflexes in general, what are the brainstem reflexes. And third thing is the drug therapy or management of a potential organ donor. If they are asking you for management of a potential organ donor, at least try to touch upon the different points, like headings, like thyroid replacement, all those things you need to touch upon. So these are the three areas. Usually they don't ask you to show all the test, very unlikely. But remember, you need to tell them, so you need to read that. And once you are having, one more thing is that once you are having a brain dead patient in your case, because this is a difficult case, honestly, if you are getting a brain dead case, either you will get a very good score in your exam, or like a negative thing also can happen. So the other area where they will go is the communication and end of life care. 101% they will ask about that. Whatever test you can say or not, ultimately the vibe will go towards how do you break the news, how do you explain. They will make a role play. They will get one technician, one nurse, one junior doctor as different relatives. They will be very ideally, ideally they will be very aggressive, like how can you say that my patient is dead? How do you say, how can you confirm? Oh, you are saying it is not yet confirmed, you need to do a test after 6 hours. Why? In between 6 hours what will happen? How do you manage my patient? So they will be very aggressive, there will be classic role play. So communication in a brain dead patient and end of life care, what you will plan, so those things also surely they will ask. Those areas the questions will go.
तो शांतनु
हाँ भाई बोलो। अभी एक्चुअली हम लोग का सेशन के बाद we are discussing some of the queries they can have. See, practical is a big session, तो सबका अपना अपना queries रहता है ना. So I told them कि जिसका जो भी query है थोड़ा discuss करो, जो भी पता है हम लोग discuss करेंगे, अभी clear out करेंगे. So they had some different areas of concern different people have, so we are discussing those things. That is about the practical engineering.
perfect. So I think the queries are over, and we are about to finish the 2 days, 8 stations, and some of the best faculties we have, the talks and the compilation of all the questions, probable questions, and the related domains as well. So if there are no more queries, so with this we conclude our session for the upcoming practicals, and we hope that you all would be doing great in the upcoming practical exam and make us proud. And we all express our best wishes and hope that you all will crack the upcoming practical exam. Thank you all. Dr. Santanu, if you want to share some of the
Nothing.
best
We have already,
wishes.
yeah, definitely. They are
Hello.
very serious. I'm
Yeah.
sure all of them will come out with the flying colors.
Yeah, they will
Very
be
sincere.
doing their best. Okay.
Surely.
So thank you. Thank you, Dr. Santanu, for all your